did this?
Sure, if I'll call you.
We can't allow Mahipal to drive home. I don't know. Ramurthy was.
We are live, ma'am.
Yeah. Very good evening to one and all of you for yet another very interesting update series on refractive surgery. And this probably would be the last refractive surgery webinar before this term ends. So whatever any of you want to learn, just stay hooked on for the next 2.5 hours. We have the best of speakers and the best of expert panel, and I'm sure there's going to be a lot of learning which is going to come through. We are lucky to have on the expert panel Dr. Mahipal Sachdev, who is the chairman and medical director of the Center for Sight Group of Hospitals. And we all know that he was a great president during his time at 2020, the AIOS. And with us joining very soon is Dr. Ramurthy, who's again chairman of the Eye Foundation Group of Hospitals, past president of AIOS, and we are lucky to have him. Joining us anytime now is Dr. Praveen Krishna, who's the Network Director, Technology and Communications, and is also the Director of the Cornea Institute and Institute of Excellence at LVPI, Hyderabad. And I'm sure there is going to be a lot of information transfer with him, with us. And joining us very soon, in a few minutes, is going to be Dr. Rohit Shetty, who is again the Vice Chairman of Narayan Netralaya Group of Hospitals, Bangalore, who is so very well known to us for that innovative scientist streak he has in him. So with such a strong expert panel and a great set of, and of course, we have Rajesh Sinha, who was to join us, but is unable to because of some last minute commitment. So with such a strong expert panel, we are just right to go. Our very first speaker is going to be none other but the young, handsome, dynamic Dr. Vardhaman Kankaria, who is the director of the Asian Eye Hospital, Pune, and of course, a very popular and a very prolific refractive surgeon of our country, and with who has had great training within the country and abroad. And he's going to tell us about how Circle brings back the smile. Now let's have a look at his video.
Yeah. Thank you so much, ma'am. Thanks to Dr. Chitra, ma'am, for the kind invite. And friends, I'm going to talk to you about a novel application of Circle software to rescue a smile procedure. We all know that smile is currently one of the preferred technologies when it comes to refractive surgeries because of being flapless, and of course, bladeless has many advantages over its pre-sedator, which is LASIK procedure. So the case I'm going to present to you is a 35-year-old female who had undergone a smile about 3 months before she presented to us elsewhere. She had undergone smile for a very straightforward 3.5 diopter myopia. So then she got relocated to Pune, and then she was referred by her surgeon for further follow-ups. When she presented to us, she reported that she started to have in the right eye a progressive diminution of vision that she noticed. But she did not go back to the original surgeon for follow-up. Neither she came to us, but she landed at about 3 months when her vision had dropped to 6/36. So this time we had seen that she had a huge amount of mixed astigmatism, and the left eye was fortunately doing extremely well. When we looked at the slit lamp, you can see that there is this 2 by 2 millimeters interface epithelial cells, which were confluent epithelial cell nest. And what was important is that this was completely isolated from the small incision. So as you understand, when you undergo smile procedure, there is a small incision at about 12 o'clock. So you have to do a fluorescein staining to understand if there is any epithelial conduct between the small incision and this epithelial ingrowth. And when we did that, the incision edge appeared to be completely intact, devoid of any epithelial fissula. And when we did the OCT, it confirmed the same. As you can see it here, there are epithelial confluent cells. And of course, the Pentacam scan demonstrated a high amount of irregular astigmatism. That is what has landed her into a poor qualitative as well as quantitative visual outcomes. Epithelial ingrowth after smile has been described, I think, very uncommonly as against in LASIK procedure. Like Sekendu et al. Has a very large series where they had demonstrated only one case of non-progressive epithelial ingrowth. And in Everson et al., they have demonstrated in 1,500 eyes that only 10 eyes had shown very small non-progressive epithelial growth only at the age, and 5 of these cases had completely resolved by about a year's time. There are only 2 cases reported in the literature of progressive epithelial ingrowth after SMILE, and both were approached from the main incision to actually remove epithelial ingrowth, and both had actually demonstrated recurrence of epithelial ingrowth. So the management options that we were left with was, of course, through going through the small incision again, or doing the YAG laser. We did not decide to go through the small incision because going through the same small incision will create a epithelial conduct to have recurrence, as it was described in the previous 2 reported cases as well. And the YAG laser, of course, is out of question because it will cause a bit of scarring at the visual axis, because this was basically isolated in the visual axis. So as Thomas Edison says, there is always a better way to do it, and we have to find it. So what we really wanted to do was we had to mechanically scrape off the epithelium. And to do that, we required the access to the SMILE interface. To have the access to the SMILE interface, the Circle software has been described in the past, which converts your SMILE cap into a flap. And this was described in the past as a tool for enhancement after SMILE procedure. So what the Circle does is that it creates actually some junctional pulses, which is between the previous cap cut and the new interface donut cut, which happens like a ring around the original SMILE cap cut. And there is a flap incision, which is created at the edge of this Circle software. So this is how it works. As you can see now, this is the donut shaped cut, and this is going to be followed by a SMILE incision. Followed by a flap cut incision. And I'm going to the same interface which was originally created for SMILE, as you can see. And we always find the same interface because there is this junctional cut which goes 20 microns above and below that lamellar cut. So I'm going, basically I've gone beyond the epithelial growth. I have relifted that flap, which is newly created with this SMILE Circle software. And now I'm debriding all the epithelial cells. Once I've done that, I'm going to go back to the under surface of the newly created flap and then remove the rest of the epithelial cells, use diluted alcohol to basically just give a nice wash so that the rest of the epithelial cells are basically dead. And then at the end, of course, I had put up a BCL for better stability. This is the slit lamp attachment of SMILE, where you can actually judge if there is any epithelial cells which are still left behind. After this, as you can see, in about 2 weeks' time, the epithelial growth had subsided. There was a very faint haze which was seen. And of course, the topography had substantially improved. The vision improved from 636 to 6/9 with a small amount of astigmatism. So when we were discussing these cases, then we realized that a couple of such cases were also done by Praveen in LVP, and also one case was done by Saeed Maaz in Hyderabad. So we put all those 3 cases together, and we published this last year in the therapeutic section of Journal of Refractive Surgery as a novel way of using Circle software for management of epithelial ingrowth. So I think the case is open for discussion. Thank you, ma'am.
Yes, Dr. Vardhaman, needless to say, it's a very novel way of dealing with epithelial ingrowth. But having said that, SMILE, these epithelial cells are actually their implantation process. Yeah. So understandably, these have very limited proliferative capacity. If it were not close to the visual axis, probably you could even watch whether they are going to proliferate. So then, keeping that in mind, it makes sense to just go through the incision site itself, and you could scrape it comfortably and wash it off with absolute alcohol, or whichever way you want to do it is the way. I would want thoughts of Dr. Ramurthy, Dr. Mahipal, and Dr. Rohit Shetty on that.
I think it's a coincidence. Just a couple of weeks back, we had a meeting in Rohit Shetty's place, and Vardhaman presented this case. And soon after that, I also presented a case of epithelial growth after SMILE, in which we had dealt it by going through the main incision. We obviously fortunately, this is very rare compared to the incidents we have after femtoLASIK or microkeratome LASIK. But we have had 2 cases in which, because it was almost abetting on the visual axis, we dealt with this. And both these cases we did through the main incision. It was, I think, about 6 to 8 months after the initial surgery. And the cleavage could be, the incision could be opened up, and we could reach the area of epithelial ingrowth and debride it. and also used 20% alcohol through the same route and washed it off, and it seemed to work quite well. My concerns, of course, this is a very elegant way what Vardhaman showed, and it has worked very well in his hands and a couple of others too. So it's only that an extra expenditure is involved, and the other issue is that there's also usually the flap or the cap gets quite thinned out over the area of epithelial ingrowth, and whether there could be a chances of any buttonhole or something if you do this kind of a procedure where you're creating a cap of a flap of a particular depth. But I think there's just two different ways of doing it. And one thing observation I have is some of us keep discussing about whether we need to wash after doing a smile procedure. Some claim better results without washing. But I feel this might be, in both Vardhaman's cases, my cases, there was no track leading up to the area of epithelial growth. So the implantation has sort of happened in our hands during the process of, during the smile procedure per se, and whether giving a good wash immediately after the procedure will wash out any remnants, so that even the rare instance of epithelial growth that we see becomes rarer is just a thought that comes to my mind.
What would be the regular circle software depth of 20 micron would you create, or would you do a little differently for an epithelial ingrowth? The junctional cut would be just as you would,
You're asking me, ma'am?
Yeah.
Yeah, ma'am, it will be similar, ma'am. Yeah, it will be similar. 20 micron above it. So
above it.
And yeah, so yeah.
Dr. Mahipal, would you want to add anything on that?
So basically, there was this particular question that's asked from me also. Fortunately, I have not had any case, but I would prefer a circle scan because as Ram was saying, the melt is not evident in this. It's a dry kind of a thing which is not very progressive. Yes. The only thing is the exposure that you get on a circle scan is much better with a flap, and then you can work on the undersurface as also on the bed. So both of them can be covered, and whether you want to apply mitomycin there or whatever, that can easily be done. So I would personally feel that this is an elegant way to do it, and I think regarding the payment, Ram, I think they have now said that 3% of your smile patients that you do, they will give circle scans free of cost. So I think that part has been taken care of. I think that was in the same meeting at Rohit Shetty that they announced that. So I think this would be, if we keep the financial thing aside, I think the exposure would be much better here. And you may not need to go back in again to take out the epithelium.
So we might implant more for all you know.
Sorry?
By opening up and creating a flap, here is just a small pocket. So,
See,
and it's just
the epithelial ingrowth that is there in smile normally does not have a pedicle thing that is coming. It's something that you have actually gone in and you have inserted the epithelium.
Exactly. Yeah.
So I don't, and you are doing a circle scan, the biggest advantage of a circle scan is that it's a fresh cut. So it's not that you are relifting a flap. If you relift a flap, then under those circumstances, yes, the chances of epithelial ingrowth increase, but not with a fresh cut.
It's
Yes, one of the reasons why you would get an epithelial ingrowth in such a case is because of excessive intraoperative manipulation.
No,
not really.
I think if it's just that basically epithelium is a nest, and you have, when you are separating it from this thing with your spatula, you just inserted it, and because it's closed and it has got between the cap and the bottom of on the upper side of the stoma. It's not necessary that if you have done more manipulation, then it will come from the periphery, and there'll be the track. The track which goes there. So this does not have any track, and it means it's an implantation of the epithelium and the of the middle of the or in the near the optical axis. So that is why.
How many of the smile surgeons here are for an interface wash? Could you raise your hand?
Just wash after regular smile? Yeah.
After regular smile.
Yeah, I do.
Okay, we haven't done, and we've just had one case, and the second one.
Just to as I commented, the two cases in which we did with this, we could have a good access both to the surface of the stromal surface as well as the back of the flap, and it worked very well. I mean, we did not have any recurrence. So obviously it has worked, but maybe going through the main incision also does not have any negatives. And
Dr. Praveen Krishna has not joined yet, Anagha, so I think you'll have to call him in later, okay? He's not here. So then we go on to our next speaker, Dr. Kavita. Dr. Kavita Rao is thanks, Vardhaman. Thanks for a wonderful thought process.
Thank you, ma'am.
Dr. Kavita Rao, who is a senior consultant, cataract, cornea, and refractive surgeries from the Agarwal Eye Hospitals, Mumbai. And she is going to show on two different cases. One is going to be an epithelial ingrowth again. And the other one she's going to show is this pressure-induced stromal keratitis. On to you, Kavita.
Thank you, ma'am. Am I audible?
Yeah.
Great. So this first case is about epithelial ingrowth. I think Vardhaman has already talked a bit about it. As we know, there are 3 grades of epithelial ingrowth, and why it must be treated is because these cells will release collagenase, which can induce the corneal flap melt, especially if it is progressive. I think that's the key, that if it is progressive, it must be treated. With initial grade 1 and 2, probably it does not need treatment, but later it has to be treated. This is a paper which I looked at. The problem with epithelial ingrowth is, of course, you're expecting recurrence. So that's the reason they recommend using sutures, because if you're not using sutures, then there's a high rate of recurrence. So here they've used fibrin glue, and around 80% almost did not have any recurrence after using the fibrin glue. So that I thought was done elsewhere. This is a case which I'd like to share. This patient of mine, LASIK was done in 2013 elsewhere. Patient presented with his decreased vision to me since 6 months. Patient had a trauma to this eye about 9 months ago, and the primary surgeon had done a flap repositioning for that. And present when she presented, her vision was 6/12, and this done cylindrical cylinder. As you can see, the epithelial ingrowth is quite extensive. It is extending all across the visual axis. And this is the OCT of the same patient showing epithelial ingrowth. I decided to take her up for surgery. Here I'm just demarcating the margins of the flap. Here it is important that after you've lifted the flap, you take out the epithelial ingrowth from the from the flap interface and for the bed, and also from the undersurface of the flap, and the epithelium beyond the margins of the flap. I think that is an important step. Here I'm removing the epithelial ingrowth which is there, and here after that I'm taking it out from the undersurface of the flap. I'm applying mitomycin C, which is applied 0.02%, actually applied for about a minute. After that, I just wash the flap, and after that, I'm applying fibrin glue here to the edges. And then it's pretty much similar. I just deposit the flap, put a BCL after cutting the excess fibrin glue. So this was the patient at 1 month post-operative, and I have been following her for almost about a year now, and there has been no recurrence. And her vision is at about 6/9 parts with a cylindrical number which has gone down. This is my second case. This was a patient who presented in April, and LASIK was done 4 months ago, and decreased vision post LASIK. This patient had a flap lift and wash done elsewhere for both the eyes. And 1 hourly steroids were being used on and off with no improvement. Now, this patient had visited almost all refractive surgeons in Mumbai with no improvement. And this was a slit lamp picture. As you can see, there was a stromal haze. The visual acuity in one eye was really bad. Finger counting not improving, and the other eye was relatively better. IOP on NCT was normal, but when I looked closely, I saw there were these fluid clefts in the interface, and patient also had guttate. When I measured the IOP on tonopen outside the flap edge, it was almost 40 in both eyes. And this was the ASOCT image, which showed that there's interface fluid. So immediately just stop the steroids and put the patient onto oral and topical anti-glaucoma agents. And within a week, the patients, if you see, the corneal haze has also cleared up. So all of that stromal haze clears up pretty quickly. Patient improved to 6/6, and he was maintained on this anti-glaucoma for almost 3 months, and patient did well. And this, you can see that the interface fluid is completely cleared up. So PISC, as we know, it's rare, but it can be seen, especially where there's this interface fluid. It's been seen after, DSEC and also SMILE. There are 3 stages of PISC. The risk factors of any surgery where there's a potential space, you can get this. And also if there's an endothelial cell dysfunction. Now, in this patient probably had these guttate, which was missed prior to surgery. And also the patient had this, it was a steroid responder. And also there was a false IOP reading because the reading was not taken outside the flap edge. So I think it's important to keep these points in mind. Thank you so much. And
thank you. So Kavita brought out very important points in each of her 2 examples. Epithelial ingrowth, how you carefully lift the flap and how you debride it, and how you use either mitomycin or alcohol, and how you debride the epithelium beyond the edge of the flap. And then her thought of gluing it, but I think even a BCL would also do, and that also could suffice. But then, and the second case, of course, how she told us about marking, checking the pressure of IUP beyond. Now, what is the essential differentiating point when you look at the haze between the pressure-induced stromal keratopathy and the DLK, which you could really suspect is, I think, DLK would be more focal deposits, and here it's a diffuse thing. But the important question here is, what would be your anti-glaucoma? You would stop steroids, but would there be any preferential choice of anti-glaucoma medication? And by different experience of different surgeons in this panel, anybody could answer, how long would you like to keep these patients on anti-glaucoma medication?
So they're basically steroid responders.
Yeah.
So that's the reason why they go in for it. So even sometimes, even within a month, you can stop.
Yeah.
The most important thing is to keep on measuring the pressure, because we have a very high incidence of, I've even kept patients for 1 year because some of them have such a bad steroid response.
Yeah.
So it's only important thing is to just keep on measuring the pressure and making sure that the pressure is not high. And also another way of checking if there's interface fluid is like when you look at the flap, when the microcystic edema goes beyond the area of the flap, then you know it's more likely to be a pressure-induced keratitis than just DLK. So that is one other way of detecting a PISC.
Yeah. Dr. Krishna? Dr. Praveen, you've joined?
Yes, ma'am, we can see him.
Yes, I'm here.
Just joined, yes.
So I want your thoughts on that pressure-induced stromal keratitis with Kavita showed. Any extra point which we should look into?
No, I think that a couple of things that are important here. One is the endothelial dysfunction, and the second is the pressure. Because when you have borderline endothelial dysfunction, even with minor changes in pressure, you can have this edema. So it would be good to do a specular of the other eye just to ensure that we're not missing anything. Because you see in patients with Fuchs, people tend to get interface fluid as well, even with normal pressures. Like Kavita very nicely pointed out, I think very important to check the pressure with a tonopen or maybe with an eye care device outside the area of the flap. And many times, even if the pressure seems to be normal, just the clinical findings of having fluid in the interface itself is good enough reason to give anti-glaucoma medications and also to give oral Diamox. Very nicely.
Yes, Anada.
The ASOCT would be the clincher in this, so as to identify those fluid clefts. Just one question I had, when you showed that you are using the glue, would you reposit the flap first and use glue at the edge, or you put glue first and then you put the flap back? Because you could have some glue going into the interface also.
Little bit glue will be in the interface. It was just at the margin, right? A little bit is going to be in the interface. It clears up, but with because you want to seal the margin, so a little bit just goes beyond, like on the flatbed. I mean, that's the way.
So would that cause any DLK or anything? Or
I looked at literature. I mean, I did none of the cases which has been reported. It has caused DLK, but yes, if it stays in the interface, you can like it probably can induce
there's some echo.
No, but Dr. Kavita, what I personally feel is.
Sir, I think you have 2 devices, so I think that's
okay. So basically, when you are doing a glue, it has to be on the outside. It should not be inside because it doesn't serve any purpose whatsoever. and you supplement it with a bandage contact lens as was rightly done. So you're supposed to put it only on the outside because getting glue inside would in any case again possibly have a difference in the apposition. So that
Space
is
will be
hard.
created.
And on the second case, the first symptom that a patient comes to you when the pressure rises is that there is a sudden fall in the vision of the patient because the refractive error changes. And if you see the patient has become myopic, in DLK, the patient becomes hyperopic if there is a melt. So that is another discerning that the patient comes back with a refractive error. Immediately the patient says, "Kal tak theek dikh raha tha, suddenly I'm having a drop in vision." And if you do an AR or whatever, it's a myopic thing and not a hyperopic. In DLK, you get melt and you get hyperopic. So that is the other important thing by which you can make out. And obviously, as Praveen said, that measuring the pressure is something very, very important. So if a patient comes back to you, often my fellows and other people miss it. The moment a patient comes back, he was fine till 4 days ago, 5 days ago, and suddenly he's not able to read 6.6, which has been recorded earlier. Pressure checking becomes very, very important.
But Dr. Praveen, would you check the pressure? Could you only with a tono pen beyond the margin, or can you even use an applanation?
I think using an appellation as long as it is not in the center, beyond off center, you can do that.
Yeah. Yes, Dr. Ramurthy?
Very nice cases and nicely demonstrated. As far as the epithelial ingrowth is concerned, just a couple of observations. One is that you mentioned using mitomycin C. I think that's something which inhibits fibroblast proliferation. Here we are dealing with epithelial cells. I personally prefer using diluted alcohol in a situation like this, where we're dealing with epithelial ingrowth, whether it's post-classic or post-smile, as we discussed earlier. And second thing is, even before you lift up the flap, because you don't want more epithelial cells going inside, before lifting of the flap, it might be a good idea to debride the from the rest of the around the edges of the gutter, so that the chance of reimplanting some more epithelial cells is somewhat minimized. And all the other things about PASK has been nicely discussed by you and the others. The only observation I have is that the propensity for increasing pressure in these patients, younger patients with phakic intraocular lenses, is a little higher. So we almost completely stuck on to loteprednol, so that the tendency for the intraocular pressure raise is minimized. And we also withdraw it quickly. Of course, endothelial pump being deficient is also another important contributory factor.
Dr. Praveen, Ramurthy having said that, I have used mitomycin in number of my, early cases, not now, earlier on, and somehow we do not see that epithelial growth rarely. So I have used mitomycin those days, and I have had complete recovery of the road traffic accident and a flap, which is sort of folded up, and then there is an epithelial growth. Those kind of pictures I don't see nowadays, but we've used mitomycin, and it definitely devitalizes those cells too. So is it a strict no-no for mitomycin? Because our results were pretty good.
Maybe those cases are done okay even without mitomycin C.
No,
but if you have to go by what works where, then obviously if you're dealing with a fibroblastic proliferation, it would be mitomycin C. And if it is epithelial cells that you want to get rid of, then it should be 20% alcohol.
Yeah, agree. I think from the point of view of epithelium that is present in a site that it shouldn't be present, it should be treated almost like a malignancy. Yeah. And when you want to kill those cells, the alcohol is the most effective method of killing those cells. Mitomycin C, maybe it's a mechanical debridement that helped in those cases, but it seems that mitomycin C probably does not have a lot of role in preventing epithelial proliferation, which is already present in the interface.
Is there any risk of a flap melt if already the flap is thinned out with alcohol? That was my fear about using alcohol, though. I looked at literature. Mitomycin C has been used in cases, and there is in fact a paper where it has been compared with alcohol, and both as you said, we don't know, because the confounding variable, had we not used anything, also they would have probably done well. Yeah, my fear in this was the flap was very thin. I was a little worried about increasing the melt. That was my only fear with using alcohol. So I don't know if that's something the expert panel feels, or that was just an unfounded fear.
No, it's a very justified concern you have, Kavita, but there, even in the couple of cases where in smile pockets, we introduced 20% alcohol and just washed it out. That was a great concern for me in the sense that it might remain there and damage the stroma as well as the cap. But fortunately, it worked out. I mean, of course, these are anecdotal experiences, just a couple of cases of using it in a smile situation where epithelial nests were there. But even in those cases, the alcohol didn't seem to cause any damage.
Sujata, you have anything to add?
I think I'll just re-emphasize what Ramuti said. Removing a 2 millimeter margin around the edge of the flap, it definitely helps because it takes at least 1 day longer for the epithelium to grow into the interface. So that buys time for the flap to stick well.
Yes, good. So so shall we go on to the next introduction?
Thank you, ma'am.
Yes, ma'am. Yeah. So we would like to now invite Dr. Praveen Krishna, sir. He is the director of the Cornea Institute and the Institute of Excellence at LVPI in Banjara Hills, Hyderabad, and also the network director of technology and communications, a brilliant surgeon and amazing speaker. Would love to hear you, sir.
Thanks a lot, Dr. Anaka, and thank you again, Dr. Chitra, for putting together so many amazing ARCs over the last years, and also for this really nice program as well. And I thought that today I'll speak about something that is a little different from typical refractive surgery. And probably the title also might be a little misleading, but you will see soon enough that this is something which is a situation that I probably haven't really faced a lot in the past. Ametropia following cataract surgery in RK, you might think, what is new about this? Because this is what all of us face and all of us live with day in and day out. And typically, there are several issues with the cataract surgery being done in a patient who's had an RK in the past, including incisions, including the phaco itself in a myopic eye, the kind of lens that you'll use, and more importantly, I think the IOL power. So at a very basic level, I think most of us have solved this issue with IOL powers in post-RK eyes, with several formulae being available. And I think most people gravitating towards the ASCRS post-RK IOL calculator because of the fact that it provides relatively decent outcomes. Now, why is IOL power post-RK a problem? Again, very basically, if there are any postgraduates who are listening in, it is important to realize that RK does cause a lot of flattening in the center. And because of this, there are two issues with measuring central keratometry. One is the fact that the exact center, the apex of the cornea, is not measured by most keratometers. You measure areas around the center. So in normal eyes, the central 3 millimeters is pretty regular. In RK, this is flattened, and so the variability in the central 3 millimeters becomes much more. The second issue is the fact that there is a change in the ratio between the anterior and the posterior curvature of the cornea, and the assumption that the posterior corneal power is a fixed amount also changes. These are the two reasons why IOL power calculation after RK is not very accurate. So what do we do nowadays? Like I said earlier, the ASCRS IOL power calculator after prior RK does not require any previous history. It just requires some metrics like the current biometry of the patient, and also, if available, the equivalent K readings or the average total power K readings from the center of the cornea if they're available. So I'd like to introduce you to a case that we dealt with some time back. Now, this is a patient who has close to 30 incisions of RK on his eye. And this patient came to the clinic earlier last year with an amblyopic eye in the right eye, and the left eye was the eye that had a cataract. So on examination, the patient was seeing pretty well, 20 by 40, but he had a cataract, and so he was advised a cataract surgery. So if you look at the topography of this patient, you will see that the topography shows that the K is extremely flat, especially in the flat axis, 17 diopters on the topography and 33, average K of only about 22 diopters. So very, very flat K readings. And this was what was entered into the IOL master to calculate his IOL power. So obviously, the IOL master did not give a reading because the flat K was flatter than the lowest limit of calculating the IOL power. So this was done by a colleague, and then at that point of time, the colleague also obtained the average K readings, EKR readings from the pentacam for the center, and also tried to calculate the IOL power using the IOL calculator in the ASCRS that I showed you a little earlier. So when this calculation was done using the metrics that were provided from the pentacam as well as the K readings from the biometer, the IOL power that was suggested, average was about 31.5 or say 32 diopters. So following this, when the colleague tried to put in the K1 as 17 diopters, which is the actual K, it was not allowing the calculation. So they had to replace this with 20, assumed K of 20, increase the K by 3 diopters, and they got an IOL power of 31.5. So apparently the lens of 38 power was implanted inside the eye, 6 diopters more myopic than what you would expect. And so you would expect that the patient would have had a good outcome. And after the surgery on post-op day 1, the patient was 20 by 400. Post-op day 7, 20 by 400 improving to 20/80 on pinhole. And at 6 weeks, the patient had a minus 12 diopters of myopic residual refractive error, correcting to 20/50. There are several possible errors that might have led to this one. One of the errors is probably the fact that the keratometry is really too flat at 22 diopters to be able to actually give out a reading on the ASCRS website. And also, when you look at the two maps, one on the oculizer and one on the pentacam, you'll see that there's almost a 10 diopter difference in the K reading. And it seems as if the pentacam was used for the EKR value rather than the oculizer, which might have accounted for a 10 diopters difference in the refractive error. And the EKR value possibly was not accurate because of this one as well. But then now we have a patient who has about a minus 12 ametropia following RK. So what would be the possible things that you can possibly do? One, we thought about contact lenses. The patient was unwilling for contact lenses. IOL exchange was another thing that we thought, but we were unsure of the IOL power. If you make a mistake once, it's likely that you can make another mistake again. So we didn't want to do an IOL exchange. We thought about a piggyback IOL, but then when we looked at the refraction of the patient, it was a minus 11 with a minus 6 at 175. So significant amount of cylinder to account for a piggyback lens. We could have put something in the sulcus, but then again, customized sulcus piggyback lenses, no experience, we were not sure what to do. Then we thought about whether we can use a phakic IOL, like an ICL or an IPCL, in a pseudophakic eye to correct for the ametropia. And when we looked at literature, there have been instances when the ICL has been used after RK to correct for residual refractive errors, and even in pseudophakic ametropia when previous corneal surgeries, including RK as well. So what we did was we actually calculated the power of IPCL, again, no financial interest, and we used a minus 15 or a plus 7 cylinder lens and implanted inside this gentleman's eye. As you can see, this is about a month after surgery. The IPCL is inside the eye. You can see the central hole. We chose a lens that has a little excessive vault to ensure that there was rotational stability as well. And after about 6 weeks after surgery in the left eye, he ended up with a minus 0.5 and a minus 0.5 cylinder 90. And he was seeing 20/25. And he said, this is the best I've ever seen after RK. So obviously, we were all very happy. So the summary of this case was the fact that this is a patient who had a significant amount of ametropia after cataract surgery in an RK eye, almost minus 12 diopters with a minus 7 cylinder, minus 11, minus 6 cylinder. But then the choice that we made was to implant an IPCL or a phakic IOL. You can't call it a phakic IOL, phakic IOL in a pseudophakic eye. And then he had an excellent outcome with this. So the difference in approach was the fact that you typically do not implant a phakic IOL in an eye that is already pseudophakic, but this seems to be a good choice in patients who have significant ametropia, especially those with cylinder, because you can't implant a typical piggyback IOL in these kind of cases. Thank you very much.
That was a brilliant case you showed us, Dr. Praveen, and a lot of food for thought. It's just that, just to get critical about it, there is a lot of so many incisions, and there is a lot of splaying of incisions and hydration of these incisions post RK after a cataract surgery. Would just a wait of 1 month have been enough? Would you have waited for 3 months? Or what are your thoughts? Because that the refraction would take a little time to stabilize. So did you check consecutive refractions to know things have stabilized? Or you were so caught up with the thought there was so much of hemetropia that the thought was which was the best option to go for?
No, the time interval between the cataract surgery and the ICL was more than 3 months. So we did wait more than 3 months.
Oh, I
So it is
heard
just that I showed the post-op follow-up at 6 weeks after the cataract surgery.
Oh, okay. Okay. So that's good. So I think the message here is that it makes sense to wait for a period of at least 3 months before we intervene for any refractive surprises which are to be expected post RK. And normally the best way would be a piggyback lens if this was a very rare situation of the high significant cylinder, and this was the only way of dealing with it, as was so beautifully shown. But the other way could have been a piggyback IOL too. Any thoughts or comments?
Can I ask a question?
Yes, yes, Sujata.
Okay, so I'm just asking hypothetically, if you're not very sure about the reading, because we know the keratometry was very flat, is it possible to do a phaco and do an intra-op refraction and then calculate the refractive, the lens power? Would that have been a possibility?
Yeah, I think, Sujata, has been one of the methods of estimating the IOL power post-refractive surgery, especially RK as well, like you rightly said. But I think with the success of the ASCRS IOL power calculator online website, I think most of us are getting emmetropia of very minimal errors like a diopter at max. And that's the reason why I think they potentially use this method. Expecting that
we also have Barrett's formulae for post-RK cases. I think they would get even better than ASCRS because there is more precision and less of averaging of values.
Madam, Barrett is already incorporated into the
so in
ASCRS.
in this particular case, the minimum and maximum, there was so much of difference. And the K was very flat, so they just had to extrapolate. So in this particular case, could it have been possible to cross-check and then do that would have been,
not really, actually. If you look at the difference in the minimum and maximum, it was only about 3 diopters. So that is the average that you would expect anyways. So I don't think the surgeon anticipated that there would be such a large residual result. I believe that one of the reasons why that the result was so off the charts was because the topography from one of the machines, the Pentacam, actually seemed to be erroneously higher. If you look back at the other topography, there's a 10 diopter difference in the topography itself in the EKR value. I think that probably is the reason.
Sir, and why was a 6 diopter myopic lens was chosen? Because you have the average minimum and the maximum. So usually we would have taken a 1.5 or a maximum 2 diopter myopic target, but here it was a 6 diopter myopic target. Any specific reason why? Because the K was so flat or any other reason?
I'm not sure. I have to check with the surgeon why. Yeah.
So normally, see what happens is more the number of incisions, you need to add a little bit more. And whenever you have these many cuts where you can't actually see the cornea, 32 cuts that you have, so those are the most unpredictable corneas. And normally the add, if you're doing at a 8 incision or you're having a 12 or something, 16, under those circumstances, the add that you do for a myopic correction is much less than what you do for 32. But obviously, this is totally off. But what Dr. Praveen did, I have also done it, not in a post-RK, but I have done it in one patient whom I had done a congenital cataract surgery. And when she became 27 years or 28 years of age, she had actually a minus 18 myopia by that time. And it would have been very difficult to remove the lens in those circumstances, and the piggyback you don't get to in such high powers. So I went ahead and implanted an ICL. So this is being reported more and more, as in difficult situations you can use this IPCL or ICL. I always use the ICL, no financial interest, but The important thing is that the chamber is normally very deep. There is no crystalline lens behind, so there is hardly any problem that you can get of any cataract or glaucoma in these cases, and they are very refractively stable as regards their positioning, much more stable than the piggyback for toric versions. So what Praveen did is really good, and you really get a bang on, because there now the corneal curvature, etc., is not anything to do with it's the residual refractive error that you have by which you are going to the implant.
Just
Yeah.
a couple of thoughts. I mean, I think excellent results in a very difficult case. I think it's the calculation also depends upon the regularity of the RK cuts. If it was a 8-cut RK or a 6-cut RK with a 3 mm clear optic zone, obviously things will work out. But the kind of cornea that Praveen showed is extremely distorted with very irregular incisions. And I think most of the formula, whether you use the Barrett 2K or the ACRS formula, they might be out of bounds, and this kind of a refractive outcome is not surprising. Maybe like Sujata suggested, what I would have done is to not do a on-table refraction, but just left the patient fake it. But a week later, done a refraction, seen what exactly the residual refractive error, and then gone ahead and multiplied it by 1.7, and still there could be some amount of approximation, but then gone ahead and implanted a lens. But I even waited for a couple of months for the RK incisions to heal up whatever refractive impact they have, and implant a lens in the sulcus. The other thing, if the primary lens implantation I had to do, I would have implanted a 3-piece lens in the sulcus, with the idea that, in case you get a inappropriate refractive outcome, wait for a period of time and then expand the lens using the residual error as the guide. Go ahead and implant a secondary, replace the lens, do a lens exchange. It would have been easier if I had placed the lens in the sulcus. And thirdly, I have been using a fair amount of piggyback lenses. And again, the source for that is not only Sulcoflex, but the same company, CAG Group. And with the manufacturers, these lenses, I've had a discussion. What they recommend is, if you want to use a piggyback lens, their piggyback lenses would be a better choice than the IPCL, because no financial interest again in either of the products, simply because those lenses are 14 mm in overall diameter. And especially when you're having a toric element and you want rotational stability, a larger lens like that is likely to be more stable than a smaller IPCL, which is really not meant for being placed in the sulcus. And I think you can get, I have got extreme powers custom made with them. And if you talk to them, maybe it's possible to get even piggyback lenses of the dimensions that you talk about. The simple calculation being for each diopter of myopia require a diopter of correction. So maybe a -12 with a -6 diopters piggyback lenses, what should go in. But anyway, it very well worked in your hands, just sharing a couple of alternatives.
Yeah, I
So,
think.
Dr. Praveen,
Yes.
one second, Dr. Praveen, I saw a small surgical iridotomy, if I can see.
Yes.
So was a trab also done? Because the surgeon
Yeah.
who does these many cuts often does a trab. So could that be a compounding factor?
Yeah, trab was done as well. You're right. There was a pretty large surgical PI superiorly. Yeah.
So I think could that also be one of the compounding factors on the topography being erroneous at times? Because sometimes these patients have a large bleb and things like that.
I think the bleb was not large. I don't think that would have been a compounding.
The RK had done enough damage to make the trab inconsequential.
No. So Ram, what the hypothesis
No, I
was
agree.
to get the pressure low. That's what this surgeon would do. So whenever we see these cases with 32 cuts, you invariably see, like I saw the surgical iridotomy. So I didn't, obviously I was not able to see the sclera. So he also does a trap for these cases. So that is another issue that comes in.
So it
Yeah.
was a wonderful discussion and a lot of information came through. Shall we go on to the next case? And Anagha, can you introduce Sujata?
Yes, ma'am. So I would like to now invite Dr. Sujata Mohan, ma'am. She's the Associate Medical Director of Rajan Eye Care Hospital in Chennai, and a brilliant surgeon and an excellent academician. Over to you, ma'am.
Thank you, Anagha, and thank you, Chitra, for including me in this wonderful session on refractive surgery. My topic is on retrieving an incomplete flap with the femtosecond laser. So this was a patient who had a 35-year-old female who came to us with a minus 2.25 SIL and a 2.25 sphere. And she was an IT professional, and microkeratome LASIK was done by an outside surgeon in our hospital. And you can see that the maps are all normal, preoperative maps. So what happened during surgery was that as he was doing the microkeratome, it just stopped. He had an electrical failure and we could not retrieve the microkeratomes. We could not do anything about it. So we had a discussion with the patient regarding whether we can convert this flap into a femtosecond flap, and she agreed. She said she wanted to get back to work, and so we decided to go ahead with the next stage of the procedure. So in this, what we did after seeing the area of the flap, I marked the external outside portion of the flap just to make sure that my femtosecond laser follows this mark to as much as possible to prevent any sliverage of tissue. And then I went ahead with a 140 micron depth cut. And as you can see that we had a very nice flap. The only thing, the air started escaping once it reached the area of the cut. And I knew there's going to be two different levels. So I first had started to dissect from the side of the femtosecond laser. It was a little bit tough to dissect. And once we dissected that, we were able to lift the flap. And you can see the two areas. There is one area which is done by the microkeratome. But fortunately, it was not in the central area. So we decided to go ahead with a laser ablation and reposited the flap and put a bandage contact lens just to keep the flap in position, and also reposited the small area of sliverage of tissue around the gutter. So bandage contact lens was applied after this, and the patient had an uneventful post-operative period. So the treatment planning, as you can see, a 140 flap thickness with an 8.8 millimeter diameter. So 4 months post-op, you can see that there is a faint line of difference where you can see between the microkeratome and the femtosecond flap cut. But the patient had no complaints, had 6/6 vision. And you can also see a slight area of flattening here when compared to the rest of the map. And this is only about 0.4 diopter difference. This is the other eye, and post-operative topography also was fine. And the ASOCT, you can see the difference between the microkeratome cut and the femtosecond laser cut. So this is something which we looked up after we did this. So there are a series of case reports by AIOS Palikaris, they've retrieved the flap on the table after having a partial flap, and 5 cases, and all of them had good results. This is again another case report of rescue of a primary incomplete microkeratome flap at a much later date, after 3 months, using a femtosecond laser. So in our case, we decided to go ahead with a femtosecond laser, and we were able to manage doing it successfully. The other options would have been to let it go and wait for about 3 months to recut or use a femtosecond laser, or alternatively, you could have done a PRK on the surface and instead of doing a femtosecond laser. But in our case, fortunately, everything went well.
Dr. Sujata, I had a call, so I missed out on one very important thing. What was the level in which you create the new femtosecond?
140. 140.
And this primary microkeratome flap was planned for?
140.
Oh, okay.
The Amadeus microkeratome, there's only one level, is 140. Yeah. But you can see, microkeratomes do not follow the same rules. So they can cut superiorly as well as inferiorly. And as you can see that femtosecond laser is at a lower level when compared to the microkeratome.
Yeah.
But you had
even increased the flap depth. That would have been even safer than going on the same level. I mean, it would have been even more safer if the corneal thickness allowed you. You did very well, no doubts.
Yeah, no. The reason why I didn't do it was then we'll get a sliver of tissue along the area of the microkeratome. there'll be a 20 micron. Suppose I do it on 120, then I'll get a 20 micron sliver of tissue. So wherever, whatever we do, we are definitely going to have a little bit of trouble because these are two different instruments with the two different way of working. So I thought this will be.
Sujata, won't an OCT have helped as to, because obviously if you are having a problem, the thickness may not be the same. It's better to do I'm sorry, again, I was partly out, but it's always better to do an OCT to see what's the depth of the flap that you have made in the first instance, and then plan your this thing, and then the sliver you won't get if you do a larger flap and a thicker flap.
Larger flap, deeper flap, you wouldn't have a problem.
No, and after an intra-op OCT, because nowadays with the you can actually see the depth of the previous flap that is there. That would be guiding factor for anybody to decide what was the actual depth, because the standard deviation in the blade keratome is significant depending on the number of times that you have used the blade also, because often blades are not used only for one eye. So
no, it's used only for one. That was the first time.
No, the sliver of tissue is more if you go for a thinner flap than the primary flap, than a thicker flap. Rather, even if you had a decentered flap, then you could go ahead and take a thicker flap below. Dr. Rohit Shetty, you are there with us?
I just joined back. I'm traveling highway, so.
Oh, okay.
So
you have missed her presentation, right?
Yes. So I'll hope to continue from now.
Yeah. Okay. No, that was, Sujata, it worked very well with you, but we want the message across that an ideal scenario, an OCT should be done, or if not, you go thicker if the corneal thickness allows, and then you are safer than taking this chance, because the primary instruments is a microkeratome, which has a standard deviation of pretty significant. You cannot be too sure about that.
But OCT definitely should have been done, but it is an afterthought. So
no, the other possibility, other possibility I'll ask, and then let's open it up to discussion. It was just in the edge. It was not even in the visual axis.
They've done a PRK.
They deposited the flap and done the PRK on the same sitting.
Absolutely. That is what we discussed with the patient. So I told him the difference between PRK and doing the flap, and the patient said, we'll go ahead with the flap. See, it is absolutely a fantastic decision. It should have been to do a PRK.
Yes.
But the decision was made like that because the patient didn't want to have any pain.
Yeah. So in all these cases where you have a partial flap, I think you wait at least for 1 day instead of making the flap. What is the hurry in making or completing the flap in that sitting itself? Because ultimately, if you have something going wrong in the axis of the eye, central area of the eye, then you have a very difficult time. So it's better to, I think, wait and do a PRK rather than doing a flap, whatever way you want to make it.
Yeah, but the thing is, this was just at the edge. It was not even anywhere near the.
Doesn't matter. When you are having a flap which might be at the edge, but if the problem comes in the center, if there's a bilaminar thing or something happens wrong with the two different planes, then you can have trouble in the central axis as well. So I think the take-home message cannot be that you take a flap whichever way you want. Take-home message should be take it easy, postpone and do OCT, whatever you want to do. And then if you think that you can do it better, or just do next day, you can do a PRK. This is what I would personally want to give the take-home message to the audience.
And one more thing, ma'am, you said there was an electrical failure. Nowadays, in most of the machines, they have a backup battery also. And if it doesn't work, it has a red signal also that gives an alert.
It was a microkeratome, not the console. Microkeratome got...
it can happen. It has happened to us. And Sujata did put forward a challenging moment, which incidentally went off great for her. But the controversy is what later showed his presentation to us for us to discuss something about it.
The reason I showed this was you wanted something controversial.
Yes, I agree. 100%. Dr. Praveen, you say anything?
Yeah, I just wanted to point out that excellent rescue by Dr. Sujata, but when you're doing the femto, if you look at the right side of the cut, which is where the air bubble actually escapes and come in front. And then the area, there seems to be a dark zone where there are no cuts by the femto. So if that air bubble comes in front, which is very common, which happens if you already have a lamellar interface, prevents further femto delivery in that area, then trying to dissect that area will lead you to the old plane of the microkeratome as well. So I think that probably is what might have happened on the nasal side. And that's the reason why we had two planes, but it went off well in the end, I guess.
No, but the other thing I could have done is I could have turned the hinge around. Instead of doing it superior, I could have followed the nasal hinge. Then this problem wouldn't have been there because it would have been the last area. That is one thing I made a mistake.
Yeah, Dr. Ramurthy, you wanted to say something?
Yeah, I mean, if there are some youngsters watching, I think the take-home message should be not to do what Sujata did. The sense that, for the first 10, 12 years of our LASIK practice, we had only the microkeratome, and we have had our share of complications with that, incomplete flaps, buttonholes, etc., etc. Best thing to do in this situation is not to do anything and just wait for a period of 3 months. And she had just a power of -3, 3.5. Do a surface ablation, it will work very well. And if at all you are so keen on doing a femtosecond flap or something, again 3 months later at a much deeper depth, but this was already at 140 microns. So my choice would have been to somehow convince the patient to hold on and then do a surface ablation without doing these things. I mean, whenever you got a cut, there's a silver up tissue, then you cannot expect the femtosecond to exactly follow the path you want. And what would have been the ultimate outcome? Just because it was not involving the visual axis, we got away with it. But obviously there were some compulsions beyond clinical reasons, because of which maybe Sujata had to do this. But I think if you want to give a message out, if you have still using a microkeratome, you have a complication with it, please don't do anything, just wait. Wait for a period of 3 months, let the corneal anatomy be restored, and then handle it like a virgin cornea.
Ramurthy, I also showed the case report by Palikaris et al., where they have on the table, they have rescued 5 similar cases using a different microkeratome.
Yeah. The other question, yes, Dr. Praveen, if this was a peripheral cut, it was nowhere close to visual axis, would you still hold to the golden period of waiting for 3 months? Or could we do it off in 1 month if the topography looks stable and good and the refraction comes to pre-op refraction, which could invariably would do? What are your thoughts on that?
No, I will say that I will do a PRK in this scenario.
Yes,
and I think
when will you do the PRK again?
I think in a month, if there's no ablation that has happened on the peripheral cut, I think a month should be perfectly all right.
Yeah, that could be also. I mean, we did wait for 3 months in our earlier years, and thankfully these problems don't happen now. But I think we could do it off in a month if the refraction stabilizes and the topography looks as if there is no peripheral steepening or any such change which has happened. So thank you very much, Sujata. You brought in more fire into the whole session. So we go on to our next speaker, Dr. Dipti. Do stay on, Sujata. We want your inputs. I call Dr. Dipti Mehra, who's the director and the consultant of Cornea and Refractive Services of Kartik Netralaya, Bangalore. And she's going to show us something more complex and more controversial. On to you. Very innovative.
Thank you, ma'am. Thank you, ma'am, and ARC for this opportunity again. So, yeah.
I'll be sharing an interesting and a very challenging case of refractive surgery. This was a boy from Andhra who we had done DALC a couple of years back for keratoconus. His unaided vision was 6/60. He's never used the astigmatic glasses which we gave. And he also had alternative squint, which he wanted to correct. So basically, he came to us for a better glass-free vision and also wanted to know if we can do something to fix his squint. Before planning any procedure on a patient who's undergone grafting, very important to see the health of your cornea and also the visual potential. So with refraction of, as mentioned here, he improved very well to 6/9 L, and he had a very good specular microscopy. So we were convinced to perform something and help him out. So we planned an excimer laser followed by a squint surgery. It was a pretty thick cornea, and even on the topography, the astigmatism was oblique in nature. So we decided to go ahead with an ablation. Now, the first decision for us was if we have to do a surface ablation or a flap. Now, OCT is extremely inevitable in such scenarios. So if you study his OCT, this is a superior inferior scan. The superior epithelium where there's no scar is around 50-60 microns, and as we go inferior, it's much thicker. So whenever you have an irregular epithelium, we also know that this can cause the astigmatism, which we are actually measuring. So making a flap would make sense because we can remove the effect of the irregular cornea. But in him, there was a significant scarring at the epithelial stroma junction. So we thought, why not do a surface ablation, and we can also help in reducing the corneal scarring. Now, what way of surface ablation? So with experience, we know that whenever there is a Bowman's membrane or deep epithelial stromal scarring, if you do an alcohol or any manual debridement, you'll really not have a very smooth surface to start off. So best would be to do an excimer laser-based removal so that you start off the actual ablation with a much smoother bed. And again, the depth of the epithelium is certainly much thicker epithelium with different areas, and scanning, we decided to ablate around 80 microns of epithelium. Now, the next question was a topo or a non-topo guided, a no-brainer here. Obviously, these are the ideal cases for topo guided. So we decided to go ahead with a contura treatment. What we noted is a very high angle kappa. So that is obvious even in this topography. So if you look at the pupil is superior nasally updrawn and is actually seeing the world with the inferior temporal part of the pupil. So if you see the left upper corner, you see when I go to this angle, he's actually, the blue line is the center of fixation. So he's actually viewing the world from the inferior nasal or inferior temporal part of his pupil. Most of the lasers are pupil-centric treatments, but here we need to make it visual-centric, especially when you have such a big deviation. So how do we do it? So we had anyway opted for the contura. In the contura, you directly go treat on the visual axis, but even if it was not a contura, we can always decenter this manually in terms of microns if the machine provides. You can see that the center green blinking light is in the inferior temporal part and not pupil center. So here again, we need to change the treatment from the pupil center to the visual axis. So imagine you're doing a treatment on the pupil, like there is almost a 1 mm deviation from his visual axis, which is actually a definition of a grossly decentered ablation. Now, image capture on the day of surgery again gets very challenging because you have a mid-peripheral irregularity and you'll never get an okay image. So you will have to do multiple scans and at least look at the central cornea. If you get a repeatable scan, you can proceed with your topography. Now, once we enter these details in the contura, we need an optic zone of at least 6.5, which gives us an ablation zone of 8.5. Now, we wanted a epithelial removal of 8.5 and a 80 micron epithelial removal with a PTK. Now, when we go in to plan our PTK, and as soon as we put 80 micron, the maximum diameter the machine is allowing is only 5. Why? Because there is a limitation of ablation when you go to the PTK mode, and all machines don't allow higher ablations and larger optical zones. So nor we can reduce your optic zone, nor can I make the thickness of the epithelium lesser. So we planned on a two-step procedure. So in the first step, I planned to remove 50 microns with a big optical and ablation zone for the PTK. And in the second step, I went ahead planning a 30 microns. So together it would be 80 microns. Now again, PTK may be pupil-centric. So it's very important you match it to your excimer ablation. So you have to decenter even your PTK so that both of them match well. So we went ahead and decentered our PTK as well. So this again is not automatic. We'll have to do a manual decentration of the PTK. Now the most important is how to get a good refraction in a patient with such an irregular cornea. So we use multiple ways of getting to know the power to the best possible extent. Obviously an dry autoref, then you do a wavefront refraction with an OPD3 scan, a very good dry and wet refraction, and always recheck yourself if the refraction done by your optometrist is perfect. Always do your duochrome and your JCC by yourself in such challenging cases to ensure that your refraction is perfect. Now the time of surgery arrives. So what we have planned here is a step 1 where we do 50 microns of decentered PTK, 2 we enhance it to 30 microns of decentered PTK, and finally we are going to do the contura ablation. So once your fixation is good and your pupil tractor is acting, so this is step 1. So you can see that the ablation is not central to the pupil. The ablation is more central to the visual axis. Now we are done with the PTK and then we start on with the contura. So it's very important to do very quick treatments. We don't want the stroma to hydrate, which can cause overcorrection. So the treatment is done. We expose the cornea to mitomycin, the time of which depends on your depth of ablation. After a thorough wash, you put a PCL. So almost a no-touch technique here. So let us look at the results. So this is a clinical picture. The corneal opacity is much lesser. Then you have your topography. When I magnify the central topography, you'll see it's much smoother. The irregularity is gone. Cornea is much flatter. And OCT is very happy picture to see where majority of your scar has disappeared. So visual results to the patient, it was an unaided 660 in that eye, which improved to 6.9 part, and a very happy patient. So only thing the patient asked that you did so much of planning and so many scans, and the surgery I thought would go on for hours, but just in few minutes it was done. So what I would say is planning is equal, or I would even say more important than the actual surgery when you're planning refractive treatments for such complex eyes. Thank you so much.
That was a wonderful thought process, but there could be two different thinking about it. To make it simple, could it have been, I would want all my expert panel to be switched on, because I definitely want a lot to come through this particular case discussion. Could it have been that you just do a PTK to regularize the topography, and then after doing that, look at the refraction, and then do definitely it needs a regularization. Even a PTK might remove that scarred area. Could you have done a topo-guided regularization for this cornea, done it as a two-step procedure? Because, manual decentration, all said and done, I mean, we have done that too for, coloboma pupil and all that in our early days. But I would wonder whether you can be repeatable in your procedure doing this way. Dr.
Sure.
Praveen? Dr. Praveen?
This was anyway a contura.
Yeah.
So there was no manual decentration.
Yeah, but the PTK decentration which you planned, you would have fed in the data, no?
Correct.
Yeah.
So I think, ma'am, for this, there are two things. First, we need to decide, are we treating a scarred cornea or is it like a refractive surgery? Like say the person where you're planning a PRK and you see a few adenoviral scars or something like that. So I think two key factors here is your vision. He was improving to 6.9 parts with refraction, which was very repeatable. So I think that itself shows that the scar is not contributing too much. And the second most thing is the topography. So here you didn't have a very irregular topo. It was a mild superior inferior difference, but it was pretty decently good topo. I think these two will help us decide. And even the clinical grading of the scar was like, I would say, a nebula grade. So I think the scar, the topography, and your vision. So if vision is less than 618, obviously we'll have to clear the scar, do the refraction, and then do it. I think these three things, we were looking more of like a refractive surgery where the scar came in between. So it was not like we are treating the scar with a PTK. I think based on these three clinical things, we either decide that it's a refractive surgery first, or it's a therapeutic where we are trying to reduce the scar and then work on the refraction. So that was probably my thought process. And also we do keep them informed that if there's a residual power, we will require an enhancement. But in him, we were mostly looking at it as a refractive surgery rather than a PTK. So I would say it's like an adenoviral scar which comes in when you're planning a PRK. So it was that sort of a thought process. But yes, I think if the similar patient comes with all these three, with a good topography, with a vision, I feel it would be quite repeatable. Okay. So I would probably do the same process if I have a similar patient again.
Just one question. Did you check what were the corneal higher order aberrations in this patient?
It was pretty okay. So I think I showed the OPD3 scan, which was decently good. It was not very bad. I don't remember it right now, but
yeah. If Dr. Rohit Shetty, sir, could just enlighten us, if you have the Schwinn platform, would it be a little more easier with a one-step procedure and where we could correct not only the scar, but also the higher order aberrations as well as with the corneal wavefront guided treatment? Are you there, sir?
Yeah, I can hear. Can you hear me?
Yes, sir, we can hear you.
Yeah.
Very good case, Deepthi, and very good results also. I think thought process was very good. Two things. If you have, let's go by, if you have two options. If you have Contura and Streamlight, which a lot of us have, Streamlight also has a transepithelial PRK. So I know you did a PTK here. But what I do is the PTK of Streamlight which takes the epithelium, is extremely more aspheric in nature and much more organized. But the only challenge is you have to tweak in something. If you don't put refractive error, you can't do streamlight. So probably you can look at next time, you can add, what I do is add a 0.25 or 0.5, a small refractive error, which does not create much change, and then do a transepithelial PRK using the streamlight. And once you do that, then you go back and do your TCAT as you would normally do. You'll get probably much more smoother how the epithelium is taken, and I think you can get probably a bigger zone. The second is, if you have the option of Schwinn, one advantage is extremely good in anything to do with scar. The reason being, you can change the peripheral and central thickness of how deep you can go based on your epithelium. So what happens is, when you say 80 microns, what I just saw in your OCT was the central and the peripheral thickness of scar and epithelium would not be the same. So sometimes what happens is that would also have an impact on your outcomes. So maybe Schwinn in that way is extremely more customizable, because you can choose the thickness from the central and peripheral. And the third is what Chitra ma'am said. You do it and then do the topo-guided later. The only challenge is, I think you answered it well, is one is she was reading well. The second is the problem is that this is a post-DALC and post already significantly multiple times operated eye. So giving an option to a patient that you will do sittings probably would be a challenge. So these are my take on it. And the next time you can probably, if you have a streamlight platform and you just have a look at it, I think it works very well. Sometimes I use that a lot to take the epithelium, because the profile of epithelial removal there is different. It's more aspheric in nature.
I agree about the streamlight, but would you get stuck about that 80 micron thing, that is why she had to do that 2-step? I've never had an opportunity to need to go that thicker.
Yeah, I don't know. I think if we can check out, whoever has streamlight can have a look at it, and probably we will know how it, because even I have not had the opportunity to do it. It might and it might not, but in Schwinn, at least you can do it. You can choose whatever depth you want, and you can choose the peripheral and central in differential way.
But that was a wonderful.
Add a little bit about what Rohit said, and I agree with Rohit about using the streamlight, because the streamlight actually does not induce a refractive error. Whereas if you do PTK mode on the EX500, it tends to induce a myopic refractive error as well. With streamlight, you can remove up to 65 microns of the epithelium in about a 9 millimeter optic zone. So that's what a streamlight will allow you. If you want to do it twice, you'll have to use 2 licenses and do 240s if you want to get to 80, or 240 and 45.
Okay. Right. Anyway, it's wonderfully done. The way you did it in 2-step, and then the way you decentered it, and ensuring that with Contura you will take care of that. So it was a wonderful surgery. Talks a lot about how you think. That was wonderful. So I'll now go on to our next presenter, Dr. Ritika Sachdev, who's a director, additional director or director, Ritika will correct me, of Center for Sight group of hospitals, and is doing majorly well with her kind of drive and energy and spirit. And she is going to talk to us about lost and found thoracic flap.
Good evening. Am I audible in my screen?
Yes.
So I'd like to thank Dr. Chitra for this opportunity. I'd be showcasing 2 cases with a similar complication, but different outcome. These are both cases of a free flap or a cap following microkeratome LASIK. We know that microkeratome LASIK can come with risks related to the flap, and free cap is more common in flat corneas and cases where the suction becomes inadequate. I'll be showcasing differences in management of two free caps. The first would be a regular free cap, wherein the stromal bed will be regular and the cap would be of uniform thickness, allowing us to proceed with the refractive correction and repositioning the cap back. And the second would be an irregular free cap. The difference in the outcome and management will be showcased. Regardless of the kind of cap, it is very important to note that we must reposit it without any rotational misalignment in order to not induce astigmatism, and we must reposit it epithelial side up. Now, with this in mind, let's have a look at both the cases. The first case, we usually mark our microkeratome cases so that in case we have any mishap, the marks allow us to realign. One thing wrong in this case is we have not really marked because the surface is not dry and the marks haven't come on. So the maneuver is misguided. You see that the free cap, the first place to look for it is in the microkeratome head. The free cap is rather regular. Fortunately, there's a slight linear cut on one side here and here. So by aligning that, we know that we can put the cap back on. Since the stromal bed is extremely regular, we have performed the ablation. Now, what we are doing is to see which side is up. I will just move back to showcase that since this is the rough side, this is the stromal side. The epithelial side is smoother. If there is any doubt, you can actually scrape the epithelial side. The epithelium will scrape off, the stroma won't scrape off. So now with the stromal ablation performed and our ability to align this cap back because of this linear artifact helping us and knowing that the epithelial side is up, we are going to try our best to align this flap and dry it to allow the flap to stick on, and in the end put in a bandage contact lens. Such a case, when managed, usually leads to a good post-operative refractive outcome, as you see in this case, and following BCL removal, the patient is 6'6", unaided. This is a similar complication of a free cap, but the difference here is that the cut has a ledge. That means it's biplanar. It's not a regular free cap. So this was performed elsewhere. Possibly there was inadequate suction leading to a biplanar pass. What has also gone wrong in this patient is that the flap has possibly been placed upside down. What happens when the flap is placed epithelial side down is that the interface epithelializes, the flap does not take on, and in fact, it undergoes necrosis. The reason we are trying to reposit this flap is because you see it is rather irregular and there is a thick ledge, and then the remaining part of the flap is much thinner. So if we do reposit this flap on the stromal surface, it will reduce the irregularity of the stromal surface because the irregularities fit in like lock and key. So that is the reason this flap is we are trying to remove the epithelium in the interface, freshen the flap margins, and putting this flap back on. I think the linear ridge, which runs right through the center, and a thicker flap on one side of the ridge and the thinner on the other side is visible. Suturing such a necrotic flap is more tedious. Also, you need to make sure that you have an equal tension so as to not induce much torque or astigmatism while suturing this flap. Once the suturing is done, things do appear to be more in order. And we follow up this patient the next day and a few days later. This is some sutures have been removed as the edema subsides and some of the sutures become loose. But what happens overall is the flap does not seem to take on, and flap melt is noted 3 weeks post-operatively, and there is no option but to let this flap go. So this is the final outcome of this patient. The misses in this patient have been that there has been an irregular flap which was not reposited properly. And hence you now have an irregular cornea. In fact, the BCVA of this patient was 6'9" partial. Patient did much better with rigid contact lenses, but did not want any further refractive procedure done. So a free flap if managed properly, is a forgiving complication, but with inadequate management can lead to a loss of best corrected vision. Thank you.
That was two brilliant cases which you showed, Ritika. And the important point which she explained to all of us who are watching there, that the stromal side is going to be a little sticky, and the rugosity on the stromal side will help you identify it if you look carefully. And if you're unsure, you could just scrape the epithelium. You'll get an epithelial defect if the epithelial side is up. So she told us that this is one thing. But when you have a free flap, it is not just the epithelium and the stroma which needs to be identified, but we also need to identify the hinge, because you need to approximate the hinge to its location, because otherwise you can have a rotational asymmetry. And in her situation, she could easily differentiate. But Dr. Praveen, can you tell us how would you differentiate the hinge, supposing it comes as a nice round circular cut? And do you think it's a challenge at all? And the other situation is, I would want an answer to that, Dr. Praveen. And the second thing is, primarily the second situation, I would have not even attempted to do so much on that irregular flap. I would have expected it not to do well. I would have discarded the flap and then allowed the epithelium to heal and then taken it forward. And if that kind of a situation happened, how would we do our management? Dr. Praveen?
Yeah, thanks, Chitra. I'll keep my video off because I'm on the road.
Yeah.
But then I think one of the easiest ways to differentiate the epithelial and the stromal side is to use a little bit of fluorescein.
Yeah.
Fluorescein will stain the stromal side, whereas it won't stain the epithelial side.
Yes.
And that will help to differentiate the two. Like you also said, and like Ritika mentioned, I think the roughness of the stroma, when you look at it under high magnification, even if the epithelial side is de-epithelialized, the Bowman's is going to be very smooth, whereas the stromal side will show that roughness. And you also might have, if it's a microkeratome, that serrated edges of the flap as well. That will help you to identify the right side.
Yeah. As far as the hinge,
I
you
think
lost
another
it?
point
His
is,
voice is not coming through.
Chitra,
Yeah.
another point is, if you do have a free cap, what I do is we taco the flap, fold it so that we'll know exactly which side we're going to deal with. We know that the stromal side is inside.
I think
Yeah.
more than anything, one point that we need to drive home is that marking of the flap is extremely important. Whoever is using microkeratome flaps, I mean, we should not just wait, because most of these free caps are all round. They will not have the hinge, and it's very rarely that you would find one linear edge. So the marking of the flap is extremely important, I think.
So basically what happens is that when you have been using a microkeratome for such a long time, you tend to not use the ink. In this case also the mark was done, and if you can see the indentation are pretty much visible on the edge. So that was one of the ways we kind of put it back. And the second thing was that essentially from where the hinge tone, that was not round. So it was an easy fit. So it's like a jigsaw puzzle, you can easily fit it there. That is what I have to say for the first year. And the second thing was that this was a new microkeratome that was being used. I think it was the ML7, which had not been used, and the pressure had been jacked up by the manufacturer or the person who had to come to give the demo. So that is, and regarding the second case, I think the biplanar flap, what is important to say is that if case, most probably because the surgeon never kind of agreed to what would have happened, but what I felt was that there was
loss.
No, it could be a suction loss, but what I felt was that there was a jam in the motor, and then back, and then again at the same time restarted it, which I think Dr. Bharti mentioned earlier also. That is something which is absolutely not to be done. So if it jams, or if you have a suction loss or whatever, if you lose, then you should not recut at the same time. So that is why you can see that there are two planes that happened, one at this and the other. And because there was so much of irregularity, I really thought that maybe we can put back the cornea and leave it. And the patient was healing well till such time that it started becoming necrotic. And ultimately, the patient had 6/9 vision, and patient is settled in US. So I don't know further as to what it is, but the surgeon who did the case did not agree as to what exactly happened with the microkeratome. So I personally feel that there was a definite suction loss, and the person went ahead, retalked, and started to, or bought the motor back and then started to recut. That's why it went into two different planes. That should never be done.
Yes.
And that's why it is very, very non-forgiving when you are using a metal keratome. If the same thing would have happened with a femto, you could easily retalk at the same time and reinitiate the whole thing and get the flap. So that is where the femto scores much, much higher as regards the safety than a metal keratome.
Mahipal, what is the, have you tried using a donor cornea and making a flap and then using it instead of the same flap that the patient?
This is my only complication that I got from somebody, and I think this is more than 10 years or maybe more. I have last I touched a microkeratome is long time back, but I haven't used a donor cornea. You can now use smile lenticules also, but the point was the biplanar this thing. So how do you get the biplanar? It's the same thing that you have to put back on.
No, you should.
And also, there are enough studies that show that when you do a microkeratome pass, actually all the flaps are a little irregular, and that irregularity actually is a lock and key with the stroma. So if you're cutting a separate flap on a microkeratome, you may as well, look at a flap amputation kind of a thing, because the risk of haze and other things may be there, but people have amputated the flap. The lock and key of the same cut, because you've cut the flap and the stroma with the same pass, that's what attenuates the irregularities. And a separate cut will not attenuate those irregularities.
No, what I'm asking is amputate the flap and use a donor cornea.
Yeah, that's what she's saying.
No.
Cornea as a flap.
Sujata, you will never get the same flap.
I know that.
The other thing is because the donor cornea will be more swollen and things like that. But one thing that this case demonstrates is the forgiveness of the cornea. See, it was a bad looking thing, and once we sacrificing a flap, I think is one lesson that one learned, that it may not be out of place to sacrifice a flap, because the cornea heals. This guy Golani calls it as cornea plastique. So this is what it shows, the plasticity of the cornea, because the patient actually, the last picture that I have, which is several years old, there is hardly a streak that is visible, and the patient had 6.
Fine.
And epithelial remodeling actually helps even up to 2 years. So post-flap amputation, the vision has been seen to improve significantly following the epithelial remodeling, because the epithelium does tend to mask out the irregularities.
Can I say something? I have used a couple of donor corneas. I've created a cap and then put it of the same thickness.
And I'll ask him to
The thing is that morphologically, it looks absolutely perfect that you have created similar size flap and put it over it. But this has some, in both the cases, what I found out was there was some degree of refractive error, some degree of astigmatism. And similarly, even if you leave the flap amputated and don't put a cap over it, then also you will get a refractive error ranging from +1 with 0.75. That also I have seen when I've left flap amputated completely in a case of a very bad epithelial growth. So morphologically, if we put corneal tissue, it really looks good, but functionally doesn't make much of a difference actually.
Yeah, sacrificing a flap, as Rajesh said, gives very little refractive error.
Yeah, but has it ever come to a point that you have sacrificed the flap and you needed that patient to be given scleral contact lenses and those kind of things? Has anybody had that kind of experience?
The refractive error that comes after that is not much. It is something like +1.5 with 0.75. Like in one of my cases wherein I sacrificed the flap because of a very bad epithelial ingrowth on the undersurface of the flap. So the refractive error was +1.5 with 0.75 cylinder. And similarly, even if you put a donor lenticule over it, there also you get some degree of refractive error and some astigmatism. So anatomically, it looks okay, but functionally, there's not much of a difference.
Yeah.
I think
Yes,
two nice cases, and I think the point that was brought home by everybody was that, when the flap becomes dysfunctional, then it's better to sacrifice it. Years back, we had a free flap. We tried to reposit it, suture it, epithelial ingrowth. And those were the times when we did not have much experience. Asked Theo Seiler, actually, he said, just take it off. And then we just removed it. I thought I am going to end up with a very bad stromal scar and very inappropriate outcome. But as Ritika showed, the case healed up completely. And 20 years later, that lady is still coming to us and the cornea looks quite pristine. So whenever you have fortunately with femtolastic with SMILE, we don't have these complications. Microkeratome, if you have a bad flap complication which is becoming unmanageable, maybe it's a good idea to just get rid of that flap and let nature take its own course. And as we saw, it does heal. Fortunately, none of us have too much experience with this, but collectively, I have seen this being said by other speakers in various meetings.
Dr. Praveen, Dr. Rohit, are you all connected? Do you have any thoughts to add?
No, just to agree with what Dr. Ramurthy said about the fact that the flap is not as critical as we used to think. It is disposable in case it is causing us more problems.
Yeah, yes. Dr. Rohit? Okay, so then Anagha, could you introduce? Thanks a lot, Ritika. Stay connected. Wonderful cases. In fact, all of you have shown.
I agree with sir, but one small comment.
Yes, yes, Dr. Rohit. Dr. Rohit, do you have a network issue?
No. I was just telling that most of the time, the free cap happens to flap which are very thin. And it's just epithelium and a little bit of stroma. When you sacrifice this, it's more of an epithelium you have sacrificed than the stroma.
Yes. Yes. Especially in those situations where the flap is started melting. And welcome, Dr. Sanjay Chaudhary and Rajesh Sinha. We missed you. So, so now there's no way you get out of it. So Anagha, could you introduce our next dynamic speaker?
Yes, ma'am. Dr. Bharati sir is the next speaker, right, ma'am?
Yes.
Yeah, ma'am. Yeah. Over to you, ma'am.
Okay. Yeah. So Dr. Sudhang Bharti is the founder and the managing director of the Bharti Eye Foundation, New Delhi. And he is going to show us a challenging case, which he has kept it hidden from all of us. So let's watch him now. You have to unmute yourself, Dr. Bharti.
Thank you, Chitra, for giving me this opportunity. And I am sure. Sorry, what has happened? Okay, so I am showing you a case of a very stubborn epithelial ingrowth. And so here we are. Epithelial ingrowth, as all of us know, is a nuisance if it keeps on occurring. Even if it's not recurring, it's very big nuisance as far as vision is concerned. A lot of astigmatism, distorted vision and everything. So this is the first case, and you can see that when I want to lift the flap, I want to mark it, and then see this epithelial ingrowth is right in the center. So that is the problem in this particular case. And in the center, when the epithelial growth is there, you have to kind of remove it, even when it is not right in the periphery and not recurrent. So you have to clean it very thoroughly, and you can clean it with the dry Marocell sponge. And sometimes when you do it like this and clean it properly, it will not come back. The only thing is you have to take it out completely, and you can just remove the epithelial growth and hope that it will not recur. Put the flap back and wash thoroughly so that the visual recovery quickly happens, and then wait for, of course, you have to put a bandage contact lens. But in all these cases where there is a epithelial growth, this is another case of epithelial growth. I think as far as I remember, this is the 6th time I am removing this epithelial growth. It's a very old case of my microkeratome, which was making the nasal flaps, the ALK microkeratome. And as you can see, this is a very recalcitrant type of epithelial growth. It is coming right up to the center, causing a lot of distortion of vision and a lot of change in the refraction. And I have to be very thorough in removing it. I'm using a hockey knife because I knew that every time I did before, it would not go away with a simple spatula. And there comes the most important thing in all these cases. I want to remove the epithelium for at least more than 1 millimeter from the periphery. So that gives time for epithelium to go up to the edge of the flap. And before the epithelium reaches the flap is stuck to the bed very strongly. So the possibility of epithelial cells going behind the flap and going on to the stroma is now the possibility is reduced. And then one has to wash it thoroughly. You can use a little bit of alcohol also. In this particular case, I also want, because I have told you this many times I have done it, in this particular case, and it was not working okay. So I am very gently, I am putting the flap on a wet Merocel, and I am removing the epithelial growth from inside the flap also, from insert in the stromal surface of the flap. And here is so these two things were very important in my opinion. The other thing is you can use a very, you cannot use a very strong alcohol, but a very mild alcohol in all these cases. And as you can see, I put the flap back and then put the contact lens, bandage contact lens on this side. Thank you very much. So this, I think if you need to discuss it, fine.
Yes. Very nice case, Dr. Bharti, and you very thoroughly showed how to scrape it from the stromal side or the undersurface of the flap. And of course, in one particular case, you have not used alcohol, or maybe you forgot to mention. I somehow feel you need to add them to kill any small focal epithelial cell nest which is lying there. Though grossly we see the larger ones and you have scraped it off. And the other thing is, I also believe that it's safer to remove some epithelium around the edge of the flap, so that, as Sujata had described, you do not allow, by the time the epithelium grows in, the flap has already adhered. So because there is so much of manipulation which occurs in these eyes. Just these two thoughts. Dr. Ramurthy, Dr. Mahipal, Dr.
Ma'am, can I ask a question, ma'am?
Yes, yes.
Yeah, sir, in these cases, excellent video, sir. So in these cases where there is recurrent epithelial ingrowth and you need to do it again and again, would you consider suturing the flap, or in which cases would you consider suturing the flap? Along with a fibrin glue also.
So I have never used a fibrin glue on the top, but I have sutured the flap more than a couple of times because of these recalcitrant type of growths, and also I have amputated the flaps also. So in all those cases, these two possibilities and options are always there. That if it is again and again growing in, then probably. So I did it almost, I would say, almost 25 years ago or so. I did suture a flap, and then it really, the epithelial growth did not happen. So this was not something very common in practice. but I did one suturing and then got rid of the epithelial growth in that case. And of course, in a case where I had it many times, then I had to amputate the flap, because as Rajesh has also shared his experience, my experience is also same, that flap, by being a planar kind of thing, it does not cause much of a refractive error, except for something like 0.5 or 0.75. You have to take care of the haze only. And since the time the mitomycin thing is available, the haze is also, the issue of haze is also quite nicely addressed. So that is why I am saying that there's always a possibility of amputating the flap. But yes, suturing I have done.
Thank you, sir.
Dr. Rajesh, don't you think that when an epithelial ingrowth is occurring just third or fourth time or second time, by the time that means there's a stromal melt has started occurring, the overlying flap would have become quite thinned out. So does it make sense to keep a flap which is questionably viable, and why not dispose it off rather than trying to save it?
Yeah, I completely agree with you. And many times what happens is there is some, instead of stromal, there is some degree of undersurface of the flap that starts melting actually. Yeah. And I had a couple of cases of flap melts wherein the epithelial ingrowth was just being monitored, and then it caused melting of flap. So this thing can happen, and there's, if I heard correctly, it was 6 times, sir, that you were removing.
Yes. Yeah, that's what I wanted to mention, Rajesh, that I have never had a single case of epithelial, the flap melt in my cases where epithelial growth was the cause. It is possible in all those cases of DALK, the DLK, not DALK, but DLK, but not in epithelial ingrowth. So there you should not confuse the two things. It's a DLK is happening, then it is not epithelial ingrowth. That's what I meant.
Sometimes what happens is
that epithelial ingrowth is not inflammatory in nature.
No, that's very true, sir. I have noticed a couple of cases where I've got a couple of cases wherein I have done SALC in these cases. What happened that there was epithelial ingrowth in the periphery, and then the patient came to us. Then we followed up just thinking that it will remain in periphery, but it proliferated, and then it lifted up the flap and then caused melting. So it caused flap melt if there is thickened epithelium. That is one thing. One, just like you mentioned here, Dr. Kavita Rao, who is here only, she was showing a couple of cases wherein on a recurrence of epithelial ingrowth, she had put that fibrin glue, what Dr. Nath was telling. And she showed that the results were good. After removing the epithelial ingrowth, she showed that she put glue after drying the edges, and long-term follow-up she showed, and she showed that the results were good. So that is that.
We just take one question, one answer from Dr. Sanjay and from Kenya, Dr. Vishal, and we have to move on because we have a number of good speakers still left.
So my experience with fibrin glue has been very good.
Okay.
In those situations where we had a recalcitrant growth under the flap, we just removed it, put the flap back, let it dry for about 2 minutes, and then put the fibrin glue all along the edge. And it worked very well. So we had 3 cases and no recurrence. Vis-a-vis the suture technique, it worked, but it caused a lot of astigmatism, which was not that acceptable.
Dr. K. Vishal?
I just wanted to point out a novel way of treating peripheral ingrowth by using a YAG laser. That is, I have used it in many cases. And the other point which I want to point out is using the ASOCT to find out the epithelial fistula. Because wherever the, whatever the epithelial cells which are communicating with the periphery, and that's why they are proliferating. So unless you do not find where the fistula is, the site of fistula has to be YAG lasered. That is also one way of tackling this recurrent epithelial ingrowths.
It's just that, yes, YAG laser could be thought for focalness because it does cause some scarring also.
Ma'am, it does not cause that much of scarring, ma'am. And this is especially for cases which are in the periphery. So you don't wait for them to proliferate and come in the center.
Yes. Thank you very much, Dr. Bharti. Lot of learning which came through. So we go on to our Dr. Anaga.
Would like to now invite Dr. Sanjay Chaudhary. Is an amazing surgeon and is a founder and director of the I7 group of eye hospitals and Chaudhary Eye Care Center in Delhi. Would love to hear your talk, sir.
Thank you, Dr. Naga. I'm just sharing my screen and so can you see me on the screen?
Yes, yes, yes.
Yes, yes.
Okay, so we have been fortunate enough to have quite a good experience with the phakic IOLs, and in that we have had a share of problems. So I thought this is a good platform to share the problems which we have faced in these situations. So the first thing, anterior subcapsular vacuolar changes. Now, what is this? Now look at this picture. On the left, you see a little haze on the crystalline lens, and on the right, you see this specular haze on a slit lamp. So on a slit, and the first impression would be that this is a visco deposit on the crystalline lens. So is this visco? Now, what was surprising is that we were doing this surgery under hydro insertion. So no visco was used except for the little teeny weeny bit in the injection cartridge, which is not expected to give such a picture of a deposit. So we had about 3-4 of such cases, and we found, to our surprise, that these cases had a spontaneous resolution in about a month's time. So this case, you see, all this has died down. So at that time, our impression was that maybe it was some visco. But then when we had a series of these cases, we looked up the literature, we realized that anterior subcapsular vacuolar changes of the crystalline lens, and if you read the conclusion part, it said direct irrigation of the narrow space between the ICL and the crystalline lens is at a risk of developing the transient vacuolar changes in the crystalline lens and observe spontaneous reversal over several weeks. So this kind of fitted what we were looking at. So there was reversal. Till we got a situation like this, where we had this large piece of deposit, and again the surgery was under hydro, and we were wondering what is this. But still we decided to follow it up, assuming it to be just transient vacuolar changes. And then this was at 3 months. To our surprise, the haze was getting denser. At 6 months, the haze was clearing up from the periphery, and it got accumulated towards the center, almost like a ring thing, which gave the impression that probably there was cell or fiber migration from the periphery towards the center, and that these corneal opacities were not actually dissolving. They were just moving towards the center. And when we did an ASOCT, this was a kind of a picture. Anterior subcapsular area, this dense lenticular opacities under it, a central area which was relatively clear. That means the opaque fibers were moving in from the periphery to the center, and this line had reached about 1.5 millimeters to the periphery. All the peripheral fibers had cleared up. So this was a picture, and we had 3 such cases. So we are trying to publish a idea of why this happens. So the inference was that do not irrigate between the ICL and the crystalline lens, come what may. So if this message goes through, maybe we would have more clear crystalline lenses in the future. The problem is that most of the beginners, they find that there is a lot of visco between the crystalline lens and the ICL, which is a little stubborn to take out, and they kind of spontaneously go under the ICL, and that is where the problem starts. The second problem we encountered were of high walls. So look at this picture. The ICL size was 12.6. That means the eye was small. And the first post-op day, we had this 1400 wall. Virtually the iris touching the cornea. And this was the right eye. On the other side is the image which goes from the periphery. It was almost touching. Fortunately, the IOP had not risen, but we made up our mind that, well, this lens has to be exchanged to a size smaller. So we ordered a smaller size. That took a while. And this is the left eye of the same patient, the same vault, 1376. At the periphery is almost following the contour of the inner cornea. And both these lenses were to be taken up for an exchange. So we ordered the lens, a size smaller, 12.1, and we waited and watched carefully that the IOP does not move. When we got the lens, this is the picture under the operating microscope. Because of this high vault and the rub on the endothelium from the ICL, there was ectropion of the uveal tissue. And look at this, I can hardly move my instrument into the eye. That high was the vault. Now, the challenge is, how do you take this lens out? Because the lens is deeply stuck into the sulcus. The usual practice which we tell everybody is you prolapse the lens out over the iris, then hold and bring it out. But in this case, there was no space. Hardly we have some visco going in. So we had to change our tactics and pick up the lens as it was lying in the retro iris space. So now we are holding on to this. We brought it out. It came out comfortably. And we replaced it with the one size lower, which means 12.1, that is about 0.5 millimeter less. Now look at the difference. From that 1400, the vault in the right eye came to 700, in the left eye came to 200. That means from 1300 to 200, 1100 micron reduction in the vault size. Now, what does this mean? That means that in short eyes, small eyes, the chances of error with a little variation in the diameter is a problem. And you can expect a sudden drop in the vault. This usually does not happen with normal size or larger eyes. The third of the worst case scenarios was a case we saw where the ICL was upside down. So this patient came to us, operated some 4 years back somewhere, and we realized that there's something wrong. There's a whole peripheral annular anterior synechia with the cornea. And on the slit lamp, the picture became obvious. The lens was upside down. That means the optics was resting on the crystalline lens, and the haptics was pushing the iris against the cornea, and there was total peripheral anterior synechia. Some of the operating surgeon kept giving them anti-glaucoma medication till finally the patient came to us. We removed this lens. We replaced it with a lens with a central hole. But what was surprising was that even after 4 years, the crystalline lens was clear. There were no lenticular opacities. That was a fantastic finding. Thank you so much.
Thank you for showing such a variety of cases, Dr. Sanjay. Always a learning. from your videos. Could you stop sharing?
Yeah, no.
The things which comes through in his you have to stop sharing.
Yeah.
The screen is still on.
Just a second, I'm just looking at.
So the important things which comes through in this is, number one, do we do a hydro implantation at all? Because then this was a typical case of an anterior capsular fibrosis. So in an eye, you do hydro implantation, a regular cataract surgery makes sense. But here, sometimes we need to twist and turn, and there could be some anterior chamber shallowing. So I think if you you don't want to use a regular viscoelastic, maybe you could think of using a Helon, which will come out in one spurt. But hydro implantation somehow doesn't strike, because there is going to be some fluid directed, because you're through the side port, you're going to take the irrigation in, and that could come in the space between the ICL and the anterior lens surface, number one. Number two, in your second case, the thing is, what amount of, this was a very high vault, but at which time would any of us think of going in and taking the ICL out? Because this particular situation, the first day, sometimes there could be some visco behind, which is actually pushing the lens forward and can give us an impression of a high vault. But you give it a few days and then see the patient again, you realize that the vault is not high at all. So at which time would you do a serial gonioscopy? How would you take a call? I mean, not this significant vault, but which vault would you actually, all of us will decide that we would intervene. And the third question is, an upside down ICL, you can easily discern the central vaulting is going to be less, the peripheral vaulting is going to be quite high. So you will also have a refractive effect by putting the lens upside down. So that would be a clearly will clinch it. I don't know why so much peripheral anti-cyanic A was allowed to form at all in the first place. But when you did remove it, I just wonder, should you have implanted the ICL right away? Because would you have rather waited to see whether those synechiae are going to reform or what? And then because the AC had already become so shallow, and would you have, there could have been some permanent angle changes also. Would you have even reconsidered putting a lens at all, ICL at all in this particular case? By my thoughts. I have some more thoughts, but let's handle these three at a time.
Yeah, ma'am. So you're absolutely right.
No, not you. I'm going to ask our
Okay,
next panel. Rajesh or Ramurthy, Mahipal, all of you, lot of discussion needed here.
No, I have used, I did do, can you hear me?
Rajesh was, I asked Rajesh first. Let him tell.
No.
Tell. Yes, Rajesh, tell. I'm going to take all.
Okay. So I do hydro implantation of ICLs. And what I feel is that I completely agree with Dr. Chaudhary and the study also that the direction of the flow should not be towards the crystalline lens, because it will not only cause those vacuoles, but it can cause flipping of the ICL also, and it can make it upside down. So the direction of flow should be towards the angle, towards the, when we are sitting on the side, so the direction of flow should be towards the nasal angle. Then there won't be any flipping, and till date, touchwood, I don't have an experience of vacuoles. That is one point.
Second,
high vault. High vault studies have shown that when you implant the ICLs, not every ICL, both the foot plates are in the sulcus. Nearly 80% of cases, the foot plates are either on the ciliary body or slightly on the zonules. And the conditions wherein one foot plate is in the sulcus and the other is on the ciliary body, the central vault is typically very high. So that is one thing I feel that in the left eye that had happened, probably it was like that. And that is why when we went just one size smaller, the vault became very low. From 1300 to it went down to 200. Perhaps that was one thing. But many times we don't actually look for it. But this is worth looking that what's the position of the foot plate. That is one.
The third case, Dr. Ramurthy, would you have put another ICL back at all?
No, I mean, obviously, in a situation like this, Sanjay did say that was a case which came from outside.
Yeah.
I think when it is very easy, just a slit lamp examination is good enough for us to find out that the ICL is upside down, because the optic of the lens would be touching the natural lens, and it will be a concavity, convexity downwards. And obviously this lens has to be taken and reversed outside. Very surprising that so much of PA is formed, and in spite of it, there was hardly any cataract that was there. But yes, this was a diseased eye, and the outcome could not have been foretold. So maybe putting in another ICL, though in the right direction, is something that is a surgeon's choice. I would rather comment on the first case. I mean, obviously, you don't want to wash behind the ICL, because there can be a risk of lens touch and cataract formation. But nowadays, I did try hydroimplantation, but as was mentioned, I find it somewhat uncontrolled. And unlike in cataract surgery, you have much lesser space here, and you don't want any damage to the natural lens or to the back of the cornea. So nowadays, I've almost completely shifted over to doing it under cohesive viscoelastic. And what I find is that once the ICL or IPCL is placed, and if it's a toric lens, it's oriented properly, just hydrating the incisions is enough to allow the entire viscoelastic to flow out quite completely. It just comes out as a bolus, and once clear fluid starts coming, I know that the viscoelastic has come out, and this makes the surgery also shorter. There's no irrigation aspiration cannula that's being introduced inside. But a very interesting series of cases that has been brought up by Sanjay. And as regards the extremely high vault case, I think if it was there, even if the replacement lens was not available, when the angle was almost zipping up and there was ectropion UVA, and I think we should have gone ahead and removed the lens much earlier, and maybe reintroduced the right side ICL, even if it takes a few days later.
I would want Anaga to say a word, and then
Yeah.
Dr. Paul's thoughts.
Sir, excellent cases, sir. Regarding those lens opacities, I also had a case where there was a little shallowing on the table because of probably little visco leaking out, and the lens actually scraped across the the surface of the lens. And that case we had seen these vacuoles post-op. So if at all you're doing it as a hydroimplantation, if there is shallowing microtrauma to the lens capsule, maybe that is one of the reasons. That was one thought. And very often nowadays we are, I mean, not very often in that sense, when we get such surprises, in spite of following the nomograms, then which only means that the lens rise in all these patients is different. So I just wanted to know how many of us are actually checking the lens rise, and how are you applying it for changing the size of the lens, even though a different lens size has been recommended.
The other question I want to ask all of you is, moving away from what the things are discussed, have any of us thought that we are making an incision here and all this SIA business is not considered at all? Cataract surgery, they talk of SIA and centroid and all that, but here we make a 3 millimeter incision and we never factor it in about, have we ever thought of that? Dr. Mahipal, your thoughts?
So anyway, I think these are almost in all cases a temporal incision, and as we know, a 2.8 incision or maximum a 3.8 incision, 3 millimeter incision is really not going to cause a significant astigmatism. So that is the answer vis-a-vis. So the company people have never calculated it taking an SIA into view, but not a bad thought, but a 0.2 astigmatism here or there does not matter. And most of these cases are very high biopsy. They all gave a line of vision. Regarding the cases, this one other take-home message is that it may not be the best idea to always do a bilateral implantation, because he got this high vault in both the eyes. So obviously he might have done it together. That's my presumption. Otherwise, I would never so I always check my patient the first post-op day before I take up the second eye. So that, and we always do a vault measurement nowadays with the Anterion or otherwise also with the AIOS OCT. So if you have a very high vault, please step back and don't do the second eye. And normally if the vault is below 1000, maybe 800, 900 at times, even doing an iridotomy at times over time helps the vault settle down to a little bit. So those are couple. I never do a hydro implantation because I always want things to be under control. And the other thing which I am slightly confused is he said 4 years or something. I don't remember, but it was 4 months or 4 years. How can a patient not develop a cataract with an upside down ICL, not have a refractive surprise, have poor vision, and not have glaucoma? Because all of these things are.
The patient had glaucoma.
Flabbergasted that this patient never had a cataract, because if it's upside down, patient has to have a cataract, and refractively patient should be very, very unhappy, I suppose.
So what about the lens rise? Are you all checking it?
Lens rise means?
So the lens rise is the distance between the
yeah, so that's the vault you are saying.
and the perpendicular to the S2S. Is anybody checking it and making changes in the nomogram? Because many times now we are seeing we are getting refractive, surprises in the vault.
Actually, crystalline size has more significance if the vault is low.
Yeah.
So if you have a low vault, even today only in my OPD, I got a patient wherein the ICL size was almost 1.3 more than the sulcus size, and the vault was low. So I thought that there can't be such erroneous kind of a vault. It was very low vault. It was just 200. So then I checked the thickness of the lens. I checked the IOL master, and the thickness was higher than the normal for that machine. So that means that the zonules are lax. So the lens rise was high. Normally, the nomogram doesn't include crystalline lens rise. So that is why we cannot do anything for that. But if it's a low vault, then it is essential to see that whether there's a lax zonules, and because of that, there's a lens rise. So in a low vault, it's important, more important.
Another important message, final message, is that you should check your white to white, and also probably do it on two modalities, a digital caliper and a topolizer kind of thing, so that is there any difference in the two when you go back and measure, and you should check both the eyes too, the white to white. If there's a discrepancy also, you need to go back and check. But there's a lot to be discussed in phakic IOL. So let's move on to Dr. Vishal.
Vishal Kenya.
You're going to introduce him, Anaga?
No. You can please go ahead.
Dr. Vishal Kenya is the medical director and
What
founder
he's
of
trying to say is
AIOS.
Vaishal. He's Vaishal.
He's Vaishal, huh?
Vaishal.
So Vaishal, founder of Kenya Eye Hospital, and he's going to be again talking about phakic IOLs and the untwisting of the ICL. On to you.
Yeah. So I'm just sharing this video of an ICL insertion. So the point which I want to make is that insertion of the ICL should be gently, not at one go. So this is the loading of the ICL. The point here is that once I'm inserting, now this insertion is just like our normal IOLs which we insert. So instead of that, if we insert in nudges, it would have been more controlled. And here I have opened the ICL in an uncontrolled fashion, and the ICL has reversed. Fortunately, I could see the trailing haptic in the wound and engaged it, and with a hand over hand maneuver, pulled the ICL out. And then again reloading the same ICL. And this time, inserting it in spurts. Thank you so much.
Thank you very much, Dr. Vishal. You showed us something very practical and relevant. I think we all know that if it's going to be an IPCL, you will have that hub on the side, left side, and for the ICL, you will see a right hole on the right side.
True.
And of course, as you said, you have to keep on anticipating that in every case, it can get upside down. And if you are carefully doing it, at any point of time, you can pull it out. Actually, on Dr. Sanjay's video also, I felt that normally, if I have to get the any ICL or IPCL out, I would first try to get the haptic out of the sulcus and then pull it out. He did it a little differently. You know, he took held on to the body of the ICL and had it out. I think he's done a big number of cases. So, but I think your case showed all the things which need to be understood. So I'm moving on, Dr. Vishal.
Vaishal.
I'm going to move on. Because we have many more speakers there.
Sure.
Yeah. We have Anaga, could you?
Yes, ma'am. Yeah, I would like to now invite Dr. Gaurav Luthra. He is the director of the Drishti Eye Institute, Dehradun, and an amazing speaker, excellent surgeon. And would really like to listen to your talk, sir. Please, over to you.
Thanks, Dr. Anaga. Thanks, Dr. Chitra, for inviting me. I have two, again, ICL short cases with where there is ICL with cataract formation. So I'll quickly start one after the other because they are both relevant to the same thing. Can you see my screen?
Yeah.
Gaurav, you are looking very handsome and diaper here. Coming from some inauguration or something?
No, sir. Holy party.
Oh, no.
Holy party.
Oh.
No, I have to go for a holy party. That's why I just got dressed up like that. So I'm sorry. I think this is the wrong one. Let me just open the correct.
And moving from one meeting to the other.
Yeah, I was in the awards committee meeting. Dr. Chitra was being, and Rajesh is also there, I think. Yes. So, Dr. Chitra was being remembered by everybody there.
Oh my God. Whatever for.
Okay, so can you see my screen now?
Yes.
Okay. So So this was a patient who was, am I audible?
Yeah.
Okay. This patient was a lady during COVID time. She went on to develop uveitis. She was 5-6 years post ICL. She came to us during 2020 summer or late summer with uveitis and bilateral uveitis. And she was treated and she was controlled. Then she was lost. She was from the hills and she was lost to follow-up. And although she was controlled initially and subsequently she came up again after 3 months with again a very bad recurrent episode of uveitis. It was, she had both vaccination and COVID, and we did all our investigations, but we couldn't find a clear correlation between the two things. But she did have bilateral uveitis, which was treated over about 6 months to 8 months and kept, getting lost to follow-up. Eventually, she went on to develop a significant cataract with a rigid pupil in both eyes, and this one was taken up for surgery first. So we wanted to get the ICL out through a small rigid pupil and under infusion because we wanted to stain the capsule as well. So we didn't use viscoelastic under infusion from the side port. We removed the ICL and got it out into the above the iris plane. And after that, it was a little challenging, but it was possible to do that. And once the ICL was delivered out, chamber was kept formed with infusion itself. And then we could stain the capsule without putting viscoelastic initially. And once the capsule was stained, so we went under the ICL to stain that capsule because it was critical to get a proper rhexis. So we stained under the ICL and got a decent stain. And after that, we thought that it would be much easier. The ICL was subsequently removed. And once the ICL was out, we decided that we had to decompress the lens because it was a very intumescent lens. So as we went in to decompress, the moment we touched it, it went into a flag sign. So this was a very big situation because this patient was planned for a toric IOL and everything went haywire. So eventually we did manage to get this cataract out, and we completed the rexis and put in a lens and managed to get a decent outcome. But when we decided to do the second eye, then we decided that we'll go ahead with a femto-assisted cataract surgery. So which we have found that has been very useful. And you can see here that we decided to do LRIs because this patient also had astigmatism in this eye. And with the usual planning, we were able to, the imaging of the OCT on the Catalyst system that we use was able to capture the images, but you can see that it is going to capture the capsular excess. For the capsular excess, the capsule will not be caught properly. So I'm sorry, I'll just move this out of the way. So we have to change the landmarks and get the capsule on the correct plane. So you can see here that after the OCT was done, the capsular excess will not be detected, and we have to manually set it and then fire the laser. So thankfully, everything went great in this patient, and we were able to get a good capsular excess. After we removed the ICL, we were able to get perfect rexis, and this was very encouraging. We've done about 4 or 5 cases like this, but eventually in one patient we had a situation. So here this eye went off quite well, and I just wanted to show that sometimes, in these eyes where there is a intumescent lens with a ICL in situ, which is not uncommon if you're getting a complicated cataract. So this can be a useful modality. But now let me just bring you to the second case, which was more challenging than this. And here goes. Is this visible now? So this was a post VR surgery eye in which there was silicone oil.
No, we don't see that.
You can't see it? I'm sorry. I'll just put it back. So is it visible now?
No, only your hospital building is seen.
I'm sorry. So I'll just stop sharing for a moment and come back. One second.
Yeah.
So then I can. So one moment. I think for some reason, this one is, if you just give me a moment. There is some problem that it's not visible. Okay, so I'll just switch it on from here. Let me just see if I can click it and show. Is it visible now?
Yeah, no, your
Doctor, you have to first open the presentation and then do the share, sir.
Okay, so it's actually a video only, but let me just, one moment. I'll just do it for a moment. Okay, so here goes, and then I'll start screen sharing. Now I'll come back to the Zoom.
But you're still seen. So how is it you're doing that?
Huh?
You should have done it beforehand.
No, it was open beforehand, but for some reason I lost it. I mean, there's something funny going on. I'm not able to even see you guys right now.
You're the guy who helps us all with these problems here.
Okay, here you go.
I know.
Is that better now?
Yeah.
Okay, I'm so sorry. It was open, but for some reason, yeah, even I can get lost in these. Okay, so I'll quickly show this because I don't want to waste time. Okay, so this patient had a post VR surgery oil in situ, and big PI was there. This patient had been vitrectomized and had gone on to develop a cataract post oil. And the challenge was that the pupil was very irregular and there were plaques, and this was a very high myopic eye. Obviously, because the ICL was there and gone on to develop, and we were very concerned about the posterior capsule integrity also. So anyway, we decentered the rexis and used that to create, because we didn't want to again have a situation with the rexis run away or anything, and went ahead with changing the landmarks, as you can see over there. And I'm moving all the landmarks for the anterior capsule so that they are not going to mistake it for the ICL. And as you can see there, once I've done that, I'm sorry. I'm messing up everything today. Anyway, so once I've done that, I can now fire the laser. And so once the rexis is done and the nucleus fragmentation was done, it's a soft cataract, get the ICL out. Now, once the ICL was out of the plane, which was again nothing exceptional, I'm sure previous videos have all shown that. Now, this was the situation that we were in. I realized that my rexis had not been completed. So this was, it can happen with the ICL because sometimes, even if you use your best changing the landmark, sometimes this will happen. And especially in this patient, there was oil in situ. So I wanted to kind of bring to the attention that if you have oil in the chamber, sometimes the femtosecond laser will not work the same way as it would work in an eye which has a totally clear. So same thing with viscoelastic. If you have viscoelastic in the anterior chamber, again, the femtosecond laser will not. However, because it had created the plane and the, kind of like a trench where the capsular rexis was to be made, we were able to complete the rexis more easily and get this cortex out. But once the cortex was out, then we were left with this dense plaque. So we kept trying to polish it for almost good 2-3 minutes. And these plaques are typically seen in these post-SOR eyes, where post-vitrectomized eyes, where oil has been there for quite some time. And we had to somehow see if we can remove this because there was no posterior support. And, sometimes these bags are also lax. You can see that I'm trying to get a plane. And once I create the plane, I was going to try and remove the capsular, this thing plaque which was there. One option was to go and do a primary posterior rexis, but it's a vitrectomized eye, and then I didn't want to take a chance. Sometimes they can cause problems. So I'm going and creating a dissection plane and finding some way of, making sure that we can remove this at least as much as I can. So once I have kind of, you can see the stress lines on the posterior capsule, I was able to create a good plane from one side to the other and detach from that area. Once that was happened, then I can go with the forceps and do a plaque peel. And of course, it is a little scary to watch, but once you come from different sides and try to peel it in different directions, you may be able to get a good PC plaque peeling. So I'll just take you to the end of this video. Once this plaque is completely removed, then of course the rest of the surgery is straightforward. So essentially, I just wanted to share that I'll stop sharing screen now. And these were the two post ICL with cataract formation. And we are going to get a huge number of these patients because the number of ICLs being done are huge. So we are going to get cataracts which are going to be much more challenging. And what I wanted to convey today was that these have to be taken very seriously because these patients can develop, unusual situations which you will not deal with in a routine cataract. So biometry is not a problem, but then the surgery can be an issue, and you have to find ways of doing it correctly in various situations that you come across.
Yeah. Wonderful videos, Gaurav. But the thing is, the occurrence of the cataract, how common it is, very high myopes, it is said it's about 1%. But are there any tips which any of the expert panel can give to the general audience, how to avoid an occurrence of cataract in a phakic IOL? Just 1, 2, 3. Because there has to be some information across. Gaurav, would you want to say that?
Ma'am, I think we have to treat these eyes more carefully. So vault has become a less of an issue now because with the center flow, even if you have a low vault, you can manage. But avoid inflammation at any cost and treat inflammation very well. Number one. One patient, I had a patient develop cataract who was into eye rubbing. And he eventually went on to develop cataract in only one eye because he used to rub his. The vault was great, but he was having allergy. So that was the second thing I found with eye rubbing, like keratoconus. And then, of course, monitor the vault. We call our patients every year for a follow-up. And if you start seeing, you can't do much about it because if the vault is going down, you'll eventually have to go for a cataract surgery, but that can take years.
What is the cutoff? Just one question. What is the cutoff to do an exchange? What is the lowest vault you will continue to monitor?
You need to observe
No,
it.
I don't think there is any cutoff at all.
Yeah.
In the sense that we have eyes with 100 micron vault and with the anterior capsule quite clear. And obviously these cases can only be serially followed up.
Yeah.
Similarly, we have eyes with 1000 micron vault also with the chamber tension under control and the angles open. So obviously these cases can be followed up.
Yeah,
As
so
regards
sub-100
what are the cases which can develop a cataract? I think one is, of course, the greatest thing is low vault, and second is higher age group. It has been proven that patients who are beyond 40 or so again have a greater propensity, and the third is higher powers, minus 15 or above. These are the instances where the incidence of cataract is much higher. Just a point about usage of femtosecond laser in the presence of an ICL. I think as Gaurav showed, not only the posterior capsule, even the anterior capsule, they quite often a fibrotic capsule, which is there. And for making a rexis in these cases is a bit of a challenge. So when you use a laser, though you don't get a free-floating rexis, most often you get a nice template. And as he showed very elegantly, you can run your rexes along those preformed lines so as to get a good rexes, and because it's very important in these cases because quite a few of them are highly myopic and your lens has to go right into the bag. You did mention that you did a difficult explantation under hydro simply because staining would not be possible. I think you should have just used a cohesive viscoelastic, my friend. I mean, you could have always then subsequently stained the capsule very well.
So, Gaurav, my 2 cents are first thing is the first thing I do is to put a stain. So even before trying anything, you have the holes there and you can actually lift the lens slightly and put the visco and it will remain there for some time. So you get a good stain. So the first thing I do is put a stain, and also when I am doing a femtocataract, this is mandatory to put a stain because there is always a possibility that the femto machine may mistake. So the other thing that I do is that I increase the size of the capsulotomy because you have a 5mm optic. That's where the line is. So if you can increase it to 5.3 or 5.4, then you miss that line and then you can get a good this thing. Always stain with trypan blue. That is the other thing. And often the pupil is mistaken as the optic. So there you have to actually increase it and do that. But as you rightly said, the balloons which are there, those have to come on and you need to mark on those particularly. And one question to you is that the first case that you showed with a huge intumescent cataract, she had a lens which was a V4 because there was a hole in the center. Then why did you do an iridotomy in that case?
So not in the last patient?
No, in the first patient, if I remember correctly, there was
first patient, there was no iridotomies. Oh, okay. No. I'll tell you. There were 2 small laser iridotomies which had enlarged very nicely. Actually, she had developed an iris bombay when she had bad uveitis. So she had come at one time with a very bad uveitis with a big iris.
That was done later, you mean? That was done later.
During her treatment for uveitis, which went on for almost about 9 months to 1 year, we had to do 2 laser iridotomies, which expanded big time, later on. So they got stretched.
Okay. Thanks a lot, Gaurav. We go on to our next speaker, Dr. Pooja Kamar, who is a senior consultant in cataract and refractive services at Narayan Nethralaya Institute at Bangalore, and we look to see her challenging case.
I'll just share my screen. Am I audible?
Yes.
Is the screen visible?
No.
So you need to click on the share screen button. There is nothing visible from your side.
Yeah, I think she's done it often enough, but I don't know what is.
Yeah. Now?
Yeah. It says that you are sharing your screen. Yes.
Yes. So very good evening. Thank you, Chitra ma'am. As everybody has mentioned, like you've done a brilliant job for past 3 years, and thank you for giving a lot of us youngsters the platform to present our work. Of course, epithelium ingrowth, everybody has shown their own technique on how they deal with it and how to go about it. So I don't need to go into basics of it. But recently we had a case of epithelium ingrowth post-LASIK 8 years. And looking at the picture and patient's history, looked like the patient did have a buttonhole intraoperatively and had blur vision. So he came to us for further management. And this was the picture. This is a classical epithelium ingrowth, what you are seeing in the patient. So, and we went ahead and did a topography for this patient. Surprisingly, the topography, because of the cells in the interface, did look like a keratoconic eye. However, it is confirmed that it's not keratoconus because the pachymetry in that area is quite good and there is no posterior elevation. You can see some anterior elevation, which you can correlate with the this one, but no pachymetry or thinnest point in this area, and the stromal elevation also was not there, suggesting that yes, this is not a keratoconic eye. Confocal microscopy also suggested that multiple epithelium cells were under the flap edge. And on OCT, we did see that the flap was quite irregular, thin than normal patients, and the epithelium was quite thick in this area with central localized epithelium cells. And the depth was around 129 microns till which the cells extended. So how do we go ahead? Of course, we do know that the treatment options are mechanical debridement, suturing, use of alcohol, and PTK. But in this case, the drawback was there were the irregular flap edges. The flap was thin. patient did have a past history of buttonhole, so there were chances of flap tear while we relift the flap, and of course a repeat epithelial ingrowth. So we decided, what do we do, like, because the area where the ingrowth was the area of buttonhole. So what new can we do for this patient? In the past, we have presented this technique, which is known as the TREC, which is the customized ablation in the area of cone in keratoconic eyes. Like, this is how it looks, and it's done on Schwinn platform, you do it just ablates the area of your cone. So we thought that, can we do the same thing here? We can just ablate the zone here and burn the epithelium cells with PTK cam mode. So we went to the PTK cam mode on the Schwinn Amaris, and we customized a PTK on just these two zones. This is how it looks. It was around 5 millimeter of area, and we kept the offset of around 0.7. So it's a decentered PTK in the area of your epithelial cells, not the entire PTK in this zone, but just a decentered PTK for 120 microns. And this is how we went ahead. This is how the surgery was. If you can see this green zone area, this is where the only challenge, like the ablation is going to happen just in the area of epithelium zones. It's not the entire area, just this zone. So the steepening, what you see on your topography, because of the heap up of epithelium cells, it's going to take care of it, and probably it's going to regularize the surface and take care of the epithelial ingrowth as well. Of course, we do see some underlying cells, so we did scrape it nicely and made sure that there are no cells remaining. And mitomycin C, as the ablation was quite deep, 120 microns. So application of mitomycin C was done for 60 seconds in this patient. And this was the post-op outcomes. If you see, the topography is well regularized. The area of steepening here has come down to quite normal levels, and you can hardly see any cells in this area. And this is how the slit lamp picture looked like immediate post-op. The epithelium defect is still there because it was on the day of surgery, and day one it looked like this. And this was the final checkup. This is just a recently operated case, so we just have 1 week follow-up. We do not have further follow-up, but looking at the vision on day 3 of BCL removal, the refractive error and the slit lamp image, we do have a hope that this patient will do quite well in terms of vision, the improvement of vision, and the epithelium ingrowth, and it might not recur. So customized PTK is a novel technique for treatment of epithelium ingrowth, causing regularization of corneal surface with minimal complications and lower chances of recurrence. And it can be planned in patients where the flaps are irregular and a past history of buttonholes. Thank you.
Yeah, that was a very interesting thought process, Pooja. But I don't know, I'm still, you reach exactly the plane, because OCG tells you what is the plane and you go to that plane and do it. Would it not, can you be sure that there is no refractive impact of the whole thing doing PTK for 120 micron thing? Normally you won't do PTK for more than 100, no?
So if you saw the topography, ma'am, it would look like a keratoconic eye, and it was localized steepening in that area. So we just decided to burn that, so it will take care of the steepening along with the epithelium cells. We do agree that we wouldn't go beyond 120 microns, but the cells were deep enough. So we had no other option, and the results were quite regular. What your concerns are is correct, but the thickness was 120 microns because a lot of it was epithelium cells. So the true ablation might have not been more than 70 or 80 microns, and maybe 30-40 microns of epithelium cells. If you see on the OCT, we could measure the epithelial cells thickness also. So the actual ablation on the epithelium and stroma was not more than 70-80 microns. So that was the uniqueness of this technique.
Anybody?
And we did take a larger zone. So the epithelium ingrowth zone was around 3.5 millimeters. But we did go to around 5 millimeters just to make sure the surrounding edges are also not having any residual cells.
Pooja, I've done this on NIDEC long time back. But is it possible to do it in this excimer, wavelight?
Ma'am, wavelight, according to our knowledge, we can only decenter it by 0.5 millimeters. Here, if you saw, the offset was around 0.65, and you can go till 1. But in streamlight, which is, or in PTK on wavelight, it can only happen till 0.5. So that is what I know. So if it's quite decenter, then you probably have to have a larger zone or have to do another technique.
Yeah.
The other way that we can do it, we used to be taught, was that you can, only the area you need to ablate, you can cover it with some viscoelastic. And then you ablate the entire area if you're not able to decenter. So it'll ablate only the area which you need to ablate. So the rest of it is covered with viscoelastic. I mean, it's not a very perfect technique, but
it can be.
But even in this, one question I had was that, how is it possible that you measure the exact area where the epithelial growth
is sitting? That's what I'm asking.
There's always a possibility that it is outside that area also.
I can go back to the thing, ma'am. Schwind has a technique where you can actually, on the topography, on your tangential anterior map, you can measure the size where the ingrowth is, measure the size where the topography is steepened, and you can just take those measurements, take the offset of that area and put it in the machine. So that is only possible with Schwind. And what the advantage to us was, yes, it's not possible in all cases, but the topography also was steepened in that area of epithelium ingrowth, so which looked like keratoconus. So we just took that advantage, a leap of faith, and did it here.
Great, Pooja. So, paucity of time, we can't dissect this case more. So, we go on to our next speaker, Dr. Sonu, who's the director of Anand Eye Hospital, Postgraduate Institute, Jaipur, and again, a very prolific veteran cataract refractive surgeon. And he's going to show us another complex case. On to you.
So, very good evening, and very happy Holi to all of you. And I'd just like to, is my screen visible and am I audible?
Yes, yes.
So,
you could start, no? Yeah.
So the slide is not moving, the video is not moving.
Yeah. Could you start and see?
Sir, I will play the video. I have your video. I will play.
Yeah. You could stop sharing.
I don't think you have the full video.
No, that is not the full video, Dr. Mr. Sunil. He didn't give it to us. He wanted suspense.
So you will share again.
Yeah, that's what I'm doing, but it's not allowing me.
It's a very important, interesting video. I don't know what is happening. Mr. Sunil,
yes, ma'am.
Should you check it on the outside and then we take Somshila before we come back to Dr. Sonugal?
So you can mail it to me, but in the meantime, we can have Dr. Somshila.
Dr. Sonu, would you do that?
Yeah.
Yeah. Okay. Anaga? She's not there. Okay. We go on to our next speaker, Dr. Somshila Murthy, who heads the cornea and anterior segment services at and the UVR services from LVPI. and again is a member scientific committee, and most importantly, a very dynamic, very astute academician and a surgeon and a friend to all of us. So there's a big list for all of us to describe you. So on to you, Somshila.
Thank you very much, Dr. Chitra, and all members of ARC for inviting me. And yes, Dr. Chitra, you've been most dynamic for these past 3 years. Am I audible, and can you see my PowerPoint?
Yes, we can.
Yeah. Okay, thank you very much. I thought the most important quality about me, Dr. Chitra, is that I'm your friend. Yes. I thought you'll say that.
No, I wanted to say that, but the thing is, others here are also very good friends.
Oh, so okay. Dharam Sankat.
Anybody down. Yeah.
So diving into my presentation. So I'm going to be discussing about how we had a very unusual flap, intern flap. And unfortunately, Sonu, I thought I'll be the last speaker, but the what do you say? The title goes to you. Last but not least. So I'm second last. So my patient, 20-year-old, comes with stable refractive error, so was very desperate for LASIK. He was slightly amblyopic in the right eye. He had -8 diopters spherical, improving to 20/60. So he selected microcatome LASIK more because of the expense. And although the only risk factors we could see for him for microkeratome was a slightly flatter cornea, his corneal keratometry was 41.2 and 42.5. But his pachymetry was pretty good. Other was absolutely normal. So we went ahead when we did microcatome LASIK for him. And this is during the COVID times. So those days we would see the patient on the same day, maybe an hour or two later, and they would go back. And the next post-operative day, we would do a teleconsultation. So the patient said that he was doing very well. And 1 week would be the next review for the patient. So this patient came back a week later, and he himself was asymptomatic. But when we examined him, I saw that the flap was actually folded inferiorly. And let's go to a high magnification image of this. So what this infolded flap shows, so it wasn't folded outward, which is what you normally expect, but was folded inward. So this is the inferior edge of the flap. And what you can see is all the epithelial cells. We've had a lot of cases of epithelial ingrowth, downgrowth. So you know that what it looks like. These are the nests of epithelial cells. This is the upper edge of the fold. It's not, it is like almost like a pleat, you can say, a fixed fold over here. And when you look at the OCT image, so again, the first arrow is denoting the inferior portion. So notice there's hardly any flap. This is almost epithelium. It is very thin actually. So that was part of the problem. This is where the flap is beginning to fold inferiorly. And this is a superior portion of the folded flap. And this is where the epithelial cells are nicely growing in and migrated below the surface of the flap. So so what we decided to do is go ahead and obviously to remove the epithelial cells and to reposition the flap. So here, the first step that I did was to debride or to remove that epithelium, which was gumming the bare surface of the stroma. And this is the edge of the flap, which is lifted up. So I'm doing it very carefully and gently, more to demonstrate also. And it's very, very thin. So that's a reason to be very, very gentle. And slowly I'm bringing it up. You can see that the epithelial cells are almost binding the flap, almost like a glue. So after spreading out the flap, the next step, I'm just trying to tease the flap open, making sure that there aren't any more folds in the flap. You can see that one prominent fixed fold. So the next step that I did was to put in some 20% alcohol, and this is to sort of kill the epithelial cells, to make them to devitalize the cells, and waited for 20 seconds, and then washed off all the alcohol from the surface of the eye. And after that, again, some more trying to remove the remaining cells or the debris and trying to iron out that fixed fold once again. So then I took a hockey stick, and with the hockey stick knife, try to manually go in and remove whatever else cells could be remaining. Because these cells are very, very dynamic. They can, again, even if a single cell remains, they're metabolically very active, they can again invade the flap. So you have to make sure that not only do you remove the cells which were in the interface, but also debride the inferior edge. So what I did a little bit later is to debride all the cells on the inferior edge of beyond the flap, actually, in that area. So all the cells I'm debriding and making sure that the flap will first stick and then those cells will grow. So if you don't do this step, as the cell starts growing in, they might once again go into the undersurface of the flap. So that is the one more important thing to be done. So after a while, this is playing again, sorry. After a while, I dried the flap and I noticed that these are all the fixed folds, and whatever I did, those folds were not going away. That is because the epithelium on the surface has also fixed them into folds. So there's no way out. What we have to do for such cases is to debride the epithelium of the surface of the flap so that the fixed fold that was here right in the center, the visual axis, can also be addressed. So this is what the case would look like at the end of all these careful maneuvers. So you would have created a defect over the area where there was a fold, but you'll see that the rest of the flap now settles in fairly nicely, and with the epithelium subsequently coming in and regularizing the anterior surface, you are likely to get a good visual result as well for this patient. So this is the end of the surgery itself, and just applying a BCL, putting in antibiotics. So 3 weeks later, you can see beautifully, if you remember the pre-operative and there's a post-operative period, in 3 weeks, the anterior surface of the cornea has beautifully fixed itself. And the patient did not have any scar, and his vision also improved even better than his amblyopic vision. So his best corrected was 20/25. He had a small refractive error, and his uncorrected he had achieved 20/40. So we published this very unusual case, but I thought I should discuss in general how we can reposit flaps which have folded up. That's it, and thank you very much for giving me this chance.
Kudos to you for doing it so well, and it's so good. So now the questions for the audiences, which I would want you to answer, is that when would you think of removing the epithelium overlying the folds? When what point? Would it be for any of those immediate situations, or would it be late situations? Would it be for microstriae? Would it be for late microstriae or late macrostriae? That is one question I have. And the second question, which I would want any of the expert panel, I think only Ramurthy's picture is there. Is it so strict that you smoothen it in the right angles to the direction of the striae as we were told so many years ago? Or do we just stretch it any other way to smoothen it out?
So I'll answer my question, which was how often do we debride the epithelium as well? I think if it is the early post-op, had this patient come if it was the same day or next day, and even if I'd seen that fold, I probably would not have debrided the epithelium. I would have stretched it and done most of the other maneuvers, except if there was ingrowth already. Sometimes even in 24 hours, you can have ingrowth. So barring that factor, if there was no ingrowth, I would just lift and wash and just as much as possible try to spread it out and unfix that fold. But if it's anything beyond that, here it was just about a week or 7 days old. So anything beyond that, the epithelium, what happens is it grows over and it creates a bridge. It sort of fuses the fold permanently. It's like putting a stitch. You take a pleat of cloth and you put a stitch across it. So that's what the epithelium does. So you have no other, nothing else will work unless you break that epithelium. So anything fresh, maybe we need not remove the epithelium. Anything older, I think we'll have to release the epithelium then.
Yeah.
That was my answer.
As far as ironing out the flap, direction of stroking.
That's for the others.
That's for the others. Yes, Sujata, you want to answer that?
No, it has to be done perpendicular to the striae.
Yeah,
so the basic idea is to stretch the striae out. And like Somashila said, we have to remove the epithelium because epithelium sort of grows into it. And like she said, it tags along with it. So once you remove the epithelium and then you keep on stroking it perpendicular, after some time, what happens is you feel that it is still not gone, but doesn't matter. You do as much as possible, but post-operatively, you'll see good results.
You have to also
put dilating the
flap.
Yeah, dilatation will help.
Put dilating the pupil help in better visibility.
That's right. Yeah, that's one important tip. I didn't do it in this case, but you can dilate so that against retroillumination, you'll have a beautiful view. So in this case, I think we just went ahead and we did the case because we were in a big hurry. In that way, we didn't dilate the pupil.
Excellent.
Excellent video and very nice description, Somashila. Very nice.
Thank you.
Important. We don't see these cases nowadays, but those microkeratome days, we had to look for that beachfront kind of thing, because the epithelium regrows. you think everything is all right, but you would see that gentle line like what you noticed a week later, which tells you that it's actually the flap which is enfolded. And the faster you get it done and put it back in place, the better it is. And I think the word you described everything very beautifully. The word you are looking for, the epithelium is tethering. The sense
That's
that,
right.
you know,
Yes, yes.
so it's sort of, if it's just a flap slippage, just a flap slippage on the first day that you notice, then you can just float it up and put it back. But then anything beyond that, you see it a week later, a month later, then it's always a good idea to go ahead and remove the epithelium, because otherwise it's going to fix the fold.
Right.
And as far as ironing out the folds are concerned, it's always perpendicular to the direction of the folds.
Yes. So we go on to Dr. Sonu Goyal, who was not to be the last speaker, has become the last speaker. On to you.
So I'll just show this smile case for 50 of my initial cases. What I want to emphasize here is the vacuum loss. Actually, you can always control with your foot pedal as to when you want the vacuum loss to occur. So watch very carefully. I have to just side cut over. So just that gives me a relief. And I have a ballooning of the conjunctiva, right? It's a loose conjunctiva, but I didn't, actually stop at this point. And what is lost here is the capside cut. So I give a call to Dr. Ramamurthy. He says, nothing doing there. Just see the picture, align itself, you can dig it, and then you can open it up. So see, what I do is, now I just try to scratch, looking on the screen where possibly this tight cut would have been, but no, this never happened. So there is no breach here. I again give him a call. He says, let's try using this level number 9, where you can actually open it up and then you can dig it inside. So what I do is I do a scratch. It's a half-pocket scratch, which I think didn't go deep, just superficial 70-80 microns here. And I'm trying to dig it up, but actually, see, what I'm doing is I'm just moving at a very superficial plane, and I'm not able to get the right plane where I could have gone inside and got up and below the lenticule. So multiple times that I do this half-heartedly, and I'm not actually able to get right into the trap. I now at this stage discuss with my patient, look, we need to, amend the procedure, and maybe we take you on a different sitting, and I put on the bandage contact lens, and I now commit one more mistake. I ask the patient, do you want the other eye? She says yes. We do successfully, and come back to this eye again, just thinking that since the other eye has been done, look. Now, what I want to emphasize is, after a few minutes of the surgery, your landmarks are over. So there are no gas bubbles. So actually, initially, I could make out with those gas bubbles what my landmarks would be. But once after a few minutes of doing the other eye surgery, my landmarks are almost gone. I still try in despair if I can figure it out. And just something clicked in my mind if I could go with the Circle software and open this and convert it into a flap and remove the lenticule, like the relax. But the Circle software, I just had 10 of them, they were all over. So there was nothing that I could do, so just wait. And then suddenly something struck in my mind. Why do I keep on struggling here? Why not make a fresh scratch apart from this area? So really just could be fast forward now. So maybe 2x. So what I do is I plan a different scratch along the circle. Yeah. So yeah. So maybe yes. Now you can, yeah, regular studio. So I make a scratch here, 1 clock hour apart, and I'm just trying to dig up again, and I'm just trying to see those white band signs what Dr. Titian has given us beautifully. So I'm trying to pick up here so that I can reach the margin of the lenticule, and every time that I go in, I'm trying to dig this part so that I can be either on top or below the lenticule. So now if you see, I've achieved, and I have trying to wriggle my way through this very small aperture. It's not even a millimeter here. And wriggling, I've gone underneath the lenticule now. So very gently, I am separating the lenticule from the stroma. Through this, if you watch carefully, through this small opening, which is just allowing this instrument to be maneuvered. So now I have separated the base of the lenticule, And now I try to figure out underneath the cap I go, gently separate, and now I move further, and look what happens is I'm trying and separate. The stump here is lost, so I have separated this half. Watch carefully, and now this half is attached to the cap here. So Gaurav has taught us that if you do a hydrodissection, so at least that water stream can, just look carefully. I push in saline now. So with this, I know that this half is separated and it is this half which has been left. So I push in the microforceps here, and gently try to do flexes of the lenticule. So I'm trying to separate here. These are few attachments here. Trying to pull this off very gently, and then I was successfully able to retrieve this. So a lot of learning here as we shift from 500 to 800 on the Visimax. So the duration of the treatment has gone from 28 seconds to 8 seconds. So gone of those days when we actually would suffer from suction losses. But with the foot pedal, we can be so smart that once the side cut has happened, you can actually titrate at what stage you can release the foot pedal and restart and read out the machine.
Yeah.
So the bandage continence, patient enjoys a quick good vision. So thank you so much for your patience.
Yeah. That was a wonderful case, and the most important thing was the learning tip there, that when you see the conjunctiva encroaching in and you realize that there is a suction loss which is impending, you could take your foot off the foot pedal and you can re-dock and carry on, because getting stuck at incision, I've had 3 situations where I made the incision, I got away with it, but just a couple of weeks back, I made the incision, it became a little too deep. Little deeper and little posterior, and I was in a bit of a trouble to get it out. So it's important to let go of the foot pedal once you know. It is very important that the incision step comes off right, rather than we do a manual incision, which we can do and get away in most situations. But like you, I did get caught too. So wonderful learning curve, and so systematically, beautifully explained. Dr. Ramurthy, are you there to add anything to it? Anybody else? Pooja, you want to say anything?
I think like sir has beautifully managed it.
Yeah.
So we had one challenge. So we had converted, like we used the circle software, reduced the incision hinge, and then we proceeded. So we usually do that. And second case which I had, luckily I had a 1 millimeter of opening. So just tried to went through it and was able to rescue the case. But yeah, usually we do similar thing.
Somshila?
Very nicely
just
done.
Yeah. Yes, Somshila.
A very well managed case. It just reminded me of when we were first doing cases, how I think that's what Pooja mentioned, that we would have an escape incision inferiorly also in the initial days when we were all starting out. And I remember that had helped me on occasions. So have a small 1 to 2 millimeter incision inferiorly, and you could sometimes remove, get yourself out of some of these messes.
Yes, Dr. Ramurthy?
No, very nicely managed, Sonu, and ultimately is the result that counts. Not only taking off the pedal when in the case of a smile, but in Visumax, when you're doing a flap also, there's a similar situation where you have the flap creation and the ultimate gutter is created right at the end. Sometimes when the suction is low, though it's quite rare, when the conjunctiva creeps in and it's coming in the area where it's going to, you're going to get the gutter, it's important that you just don't proceed and hit the conjunctiva, because that means you won't have a peripheral ledge to go ahead and lift up the flap. So I think the same principle as what you're mentioning for smile incision applies to femtosecond laser flaps also.
Yeah. So thank you very much, one and all of you. I'm so sure each of us learned a lot in the course of these 2.5 hours, and it goes without saying our audience would have learned too. So thank you so much, very dear expert panel. You were there, most of them, till the end, and Ramurthy stayed right till the end too. But then I realized that each and every one of you, and yes, Dr. Rajesh too, he comes in and goes, he has his magical way of being there when he's needed most. He's scared of getting banged by me the next day, I think. So, and I think this was one session where I felt that any one of you could have been the expert panel, because each of you have tons of experience and enough knowledge to have taken it forward and done it very well. Thanks a lot. And I need to thank my co-moderator, Anagha, who was so intensely, continuously along with it as I was. So it was such a big relief for me. And I need to thank AIOS, Mr. Kripal and his team for being supportive always and making note of my dates and sending those SMSs. I need to thank Sai and Manjula from Numerotech for the mailers which reach our everyone so that you are updated about the meeting. And of goes without saying that we really, really need to thank Mr. Sunil, the way he's there throughout all these 3 years. He's been like that and always been a big support. Hats off to you, Mr. Sunil, for your patience and your constant support. And of course, we need to thank Entod always, because they have been my sponsors for all of my programs, and 3 cheers to them for being so supportive at all times. And finally, and most importantly, I need to thank all those attendees who have watched. I'm sure I'll be posting to you all at the end of it. There'll be a good number who have watched, because Sunil would update me, and then they keep watching it later also. So believe me, each of you have outperformed yourself, and this would be a webinar to be remembered and to be showcased for a very long time. Thank you very, very much.
Thank you. Good night. And wish you all a very happy
Thank you,
Holi.
Chitra ma'am.
Yeah, happy Holi to all of you.
Happy Holi to everyone.